and scientific methods by experts from esteemed institutions who have proven expertise.
अभी एक बार आ गया, अब नहीं आएगा फिर से। हेलो।
The organizing committee extends a very warm welcome to all the speakers for CME. We shall start the proceeding shortly with the inaugural session. I request you all to please keep your mobile phones on silent mode. All the audience who are sitting here are also requested not to log into CME from Zoom from here. On behalf of Research Cell, All India Institute of Medical Sciences, Rajkot, it is my pleasure to welcome all speakers and delegates from India and abroad who have joined us online and distinguished guests present with us to the inaugural session of National CME on Research Methodology. It is our proud privilege to have amongst us Professor Dr. Colonel C.D.S. Satosh, Executive Director, AIIMS Rajkot, as the chief guest for the CME. Sir has been the pillar of support for all our endeavors and Sir deeply values this CME. I now request Dr. Ashwini Agarwal, Dean Research and Organizing Chairperson for CME, to welcome Executive Director, sir. Before we begin our CME, we have the honor of partaking in a time-honored tradition, the lamp lighting ceremony. Knowledge is a lasting inner treasure which adorns the mind by the light of wisdom. Just as the brilliance of light does not diminish, so too the knowledge when shared with others. Hence, we light the lamp to go down to knowledge as the greatest of all form of wealth. We shall now commence our inaugural session by invocation of Goddess Saraswati and lighting the traditional lamp. I invite Executive Director Sir on stage to light the lamp and officially inaugurate our event. I also request Dr. CME Madam, Dean Examination, Dr. Sanjay Gupta, Dean Academics, and Dr. Ashwini Agarwal, Organizing Chairperson for this CME, to please join the Executive Director Sir on stage and open honor.
बैटरी बदली लो।
Very good afternoon to all the delegates who are present here offline and those who are present online. And my sincere thanks to all the speakers who are connected with us, sparing their valuable time to disseminate the academics. Warm welcome to you all for this National CME on Research Methodology organized by Research Center of Rajkot. It's a matter of immense pride and honor to witness this gathering of over 2,500 registrants from India and abroad. A testament to the relevance and importance of research in today's rapidly evolving healthcare landscape. This CME brings together some of the brightest minds of the country and beyond, with experts from institutes of national importance and other prestigious institutions of global repute. Their presence enriches this event, offering all of us unique opportunity to gain insights from their immense experience and expertise. The session planned will cover critical aspects of research methodology, a foundational pillar of medical advancement, and are designed to equip participants with the skills required to conduct high-quality research that will ultimately benefit patient care and healthcare system worldwide. At AIIMS Rajkot, we have always strived for excellence. In a very short span of time, this institute has grown by leaps and bounds, both in infrastructure and academic capacity. This remarkable progress has only been possible due to dedication, hard work, and vision of the dynamic team I have the privilege of leading. Their passion for advancing healthcare education and research has been instrumental in elevating AIIMS Rajkot to where it stands today. I would also like to express my heartfelt gratitude to the research cell for organizing this two-day CME, a significant step towards fostering a research-centric culture in our institute. Research is at the core of modern medicine, and nurturing this culture will ensure that we continue to contribute meaningfully to medical science, public health, and patient care. As we continue to grow, our focus remains on developing AIIMS Rajkot as a center of excellence for healthcare research, academics, fostering collaborations at national and international levels. This CME is a perfect example of how we are moving towards that vision. I extend my sincere thanks to all the participants for their overwhelming response, to our speakers for sharing their knowledge, and to the organizing team for making this event a reality. I hope that each of you takes back valuable lessons and ideas that will inspire you on research journeys. Once again, welcome, and I look forward to a grand success of this CME and this will benefit all of you. Thank you.
We extend our heartfelt thanks to Executive Director Sir for his inspiring words. We are truly privileged to have had the opportunity to hear your thoughts and insights. Thank you once again, sir. So, without further ado, I request Dr. Ashwini Agarwal to deliver the introduction of CME.
Thank you, Dr. Bhumika. At the outset, my sincere apologies for the technical glitches. Research is to see what everybody else has seen and to think what nobody else has thought. These are the work of this Nobel laureate who got Nobel Prize in Physiology, Medicine in 1930. And very true. The research starts with a thought, may not be out of the box, but a thought is required, an idea is required, and once you have that idea, then this idea has to be converted into a study, into a research proposal, and into a final your research. So this process of converting your idea into your research proposal is what is research methodology. It's a systematic and scientific process which leads you to discovery, but research as such is just search for knowledge. So you have an idea, you have some information, to do a scientific and systemic search on that particular specific topic, and there are many steps involved in it. This definition of report moving is defines various steps which are involved in research. First is you have to identify the problem, define the problem, suggest a hypothesis, collect, organize, and evaluate data, and making deductions and reaching conclusions, and finally testing your conclusion. So there are many steps, starting from your idea to evaluate, to do a literature search, formulate your intent objective, formulate your study design. It is very important what type of study you are going to do, on what population, what will be your sample size, and how are you going to statistically analyze it. We generally deal with healthcare research, so in that ethics part also becomes important. And finally, writing part. So in this, we have got we will be covering each and every aspect, starting with Dr. Umesh Kapil, who is stalwart in field of research, in healthcare research. He will be giving keynote address on research in healthcare, and followed by different steps which are involved in research, starting from various strategies, various research design, epidemiological studies, experimental studies. We will be covering today, and tomorrow we will be covering the other aspects like bias, conforming factor, sampling factor, statistical analysis, ethical aspect, and finally how to write a research proposal, which will be helpful for our young researchers. I'm sincerely thankful to all the speakers who have spared the valuable time for this meeting. And I hope all the participants, they are benefited with it. We have got 7.2500 plus, but current count is 2800 plus. If we have got participants from all over the world, other than India, we have got participants from more than 15 countries. I sincerely hope that you will be benefited with this CME. Thank you very much. Happy learning. Jai Hind.
Thank you so much, sir. We shall now begin with today's deliberations. Delegates may post their queries in the chat box. We will try to address them at the end of the session. In case we are unable to take your questions today due to paucity of time, we will surely revert back via email. Now, I would like to invite our speaker for keynote address on the topic research in healthcare. Ladies and gentlemen, it's an honor to introduce our esteemed speaker, Professor Dr. Umesh Kapil, Secretary, National Academy of Medical Sciences and President of Epidemiology Foundation of India. Sir is former Professor and Head of Department of Gastroenterology and Human Nutrition in New Delhi. Sir has received various national awards, including the prestigious D.C. Srivastava National Award, T.N. Raju ICMR National Award, and M.K. Seshadri ICMR National Award. Dr. Kapil elected as Fellow of National Academy of Medical Sciences 2003, Fellow of Indian Public Health Association 1993, and Fellow of Indian Association of Preventive and Social Medicine 1998. Sir has 379 publications to his credit. He is among the list of world ranking of top 2% scientists published by Stanford University 2023. Over to you, sir, Dr. Umesh Kapil.
Very much to respected Colonel Katoch Saab, CEO, AIIMS, Rajkot, Dr. Ashwini, Dean Research Section, my dear friend Krupal, and all other dignitaries. My most sincere thanks to all of you for giving me this opportunity to deliver the keynote address. The number of participants which have joined or have got registered speaks of the popularity of the team Rajkot, which is a very, very important institution of Government of India in Gujarat. I would like to show the first slide, please. नहीं तो लास्ट दिखा रहे हो तुम, पहला स्लाइड दिखाओ. Now, if you ask me research, I am in this game for last 40 years, maybe a little more than that. Next. Now, if you look at the research, it can be at all the levels. It can be on the policy planners and administrators at the central level. Central level people, they decide certain policies that this should be done. And then it goes to the state, and the state level people give it to the district. By and large, even each and comma, full stop, dots in the policy document which are being developed by the government of India are being followed at the state level. By and large, because 90 to 95% of the funding to the state comes from the government of India. Now, ultimately, all these guidelines, programs which are being initiated get converged at the village level. And at the village level, it is expected that all the programs which are being implemented in the country, they have to be implemented by whether it is ANM, ASHA, ICDS, Anganwadi worker, or any other village level worker which we have. So this is something we must keep it in mind, that how the policy goes from central level to the state level. Next. Now, if you look at the research, we may do large number of research, doesn't make any difference. We may publish, we may get promotions, but what is important is research should be able to influence the policy. I'll give you examples of that little later. And then policy should get into the programs. Ultimately, policy may be anything, but the program is the one which gets implemented in the state or the village or the district level. And the last is operationalization of these programs, these health issues, which is very, very important. Unless and until these programs are not operationalized as conceived in the policy or in the program, it is just good for nothing. Next. Now, if you look at the country, we have more than 30 national health programs, little more. All the national health problems, which includes diabetes, malaria, tuberculosis, leprosy, diarrhea, anything you name it, which is present in all over the country, which has a significant magnitude in all the states, we have a national program for that. So if you look at the healthcare, we need to look into these national health programs very carefully. And there are certain state-specific programs also, like say Kala Azar for Bihar. And there are specific programs which are there. Next. Now, all these programs depends upon the political and administrative commitments. A politician makes sure, oh, you have to do it. So chief secretary, health secretary, everybody does same. And then it also depends upon the financial resources which are available at the state level for implementation of the program. For example, we had a very clear-cut example of COVID immunization. All over the country, 140 crore people were immunized. We have still going on the polio program. So we do have program, we do have infrastructure. It's the political commitment and administrative commitment changes from time to time. Next. Now, the two issues we must remember that. We have large number of studies which show the efficacy. That under a very controlled condition, you undertake one particular thing, you show it. I'll give examples for that. And you show that, you publish it, and you show it to the world, look, this thing works. Now, but when it comes down to effectiveness is that under the real public health intervention conditions, how does it work? Are we able to achieve the objectives with which the program is being implemented? This is something very important. We forget about our peripheral health worker. A&M, she becomes pregnant. She takes 6 months leave. Asha, she also undergoes certain family issues. She also, A&M have a earned leave. She has a sick leave. So when these people go on leave, program suffers. We have to look into all these issues when we are looking at the healthcare. Next. Now, if you go to the village level, the primary health care is the most important thing all over the world. In fact, in 1978, we had the Alma Ata Declaration when we talk about the appropriate technology, availability, there were 8 A's. And what happened? That we looked into the primary healthcare, how that should be supported. And main focus in 1978 was universal health coverage. Even today, the most important thing is universal health coverage. There are large chunk of areas within the same district, same block, same tehsil. There are areas which do not have any health coverage facilities. Next. Now, everybody says that the primary health care is the cornerstone of functioning of the health system. And for this, how the primary health care is being done, we need to have a high quality data which is required. Usually what we have is that the tertiary care level services, they receive almost 75% of the total funding. And very meager amount goes to the village level or to the primary health care. This system needs to be improved because the so-called politicians, bureaucrats, when they have the MI or heart attack or anything, we find that CN tower, cardio-neurology center tower gets say raised up. So there is need of increasing the funds. Next. Now, these are many top priorities which we have. We have Government of India have initiated many programs, and one of the most important is Ayushman Bharat. We have the digital mission which have been initiated. We have talked about that every patient who gets into the hospital gets a registration. Now, these are some of the very, very important initiatives which have been done. We have started the telemedicine. All the AIIMS in the country have been given the telemedicine facilities. They can also get linked up with different peripheral health institutions at the village level, block level, so that they can provide the top class or best healthcare services. Now, again, once you can provide the infrastructure, you can provide the manpower, but then the supporting facilities needs to be looked into. That's very important. And what is the current status? We are not aware about it. Next. Now, if you look at a long time back, 1999, 1990, there's a gentleman, Abhay Bang, and his wife, Rani Bang. They're working in Gadchiroli area of Maharashtra. They're outstanding. They're very committed people. Now, they have published a paper in 1990, reduction in pneumonia mortality and total childhood mortality, community-based intervention. They had about 100 peripheral health workers, women workers. They were given, and particularly antibiotic injections. Any person who had any child who has these 5 symptoms should be given this injection, and results were very fine. Similarly, the home-based neonatal care, they showed the path that here you can reduce the neonatal mortality because as all of you know, amongst the under 5 mortality, 50% is infant mortality. Out of infant mortality, 50% is neonatal mortality, out of which another 50% is in the first week. So they showed a very good example, but it could not be repeated in any other part of the country. ICMR initiated 5 center studies, nothing was achieved. Why? Because of operational reasons, because of the commitment of the people who are implementing this program. Next. Now, similarly, way back in 1986, there are 2 American scientists. They showed that in a block, if you give mega dose of vitamin A 6 monthly, there's a reduction of under 5 mortality by 30%, 86. Now, bureaucrats, they are just looking for some data, some magic pill or magic solutions. That if we do it in our country, it might work. And all over the country, we had universal vitamin A supplementation. In fact, in 2001, they started the vitamin A dose along with the pulse polio immunization, universal coverage. But does it help? No, because number one, the scientists in this country could not produce the data that which can convince the policymakers that this is not required. Okay, I must congratulate Indian Academy of Pediatrics. 2002, a strong position was taken, and then it was delinked because the data was produced that it doesn't make any difference. Next. I'll just give another example. Zinc dispersible tablets. If you give ORS alone, and if you give zinc tablet, this zinc dispersible tablet made in a solution and give it to the mother, give it to the child suffering from diarrhea, there's a reduction in the overall period of diarrhea. Mortality gets reduced. Now, this zinc dispersible tablet, which Dr. Bhan tried, he was Secretary DBT, a very eminent scientist. He ensured that in a teaspoon, if mother can take out breast milk of 5 ml, this dispersible tablet can be dissolved. And then it can be, after the ORS, this 5 ml milk can be given, because water safety is another issue in the at the village level. But what happened? Quotations were given, these zinc tablets were produced. There were no testing that it dissolves in 5 ml or it gets dissolved in 20 ml. It was a non-dispersible tablets. They were supplied in the AIIMS kits all over the country, and no guidelines, no training was done. It was presumed that the CMOs would give training. What happened? The AIIMS, they thought that some zinc tablet has come and is something very useful, so let's give it to the pregnant mothers. So these tablets were given to the pregnant mothers, never used. Similarly, we had example of iron tablets. We had the blue side, if we look at this, these were the blue entry-coated IFA tablets. And on the red color, it is 100 milligram tablets. Entry-coated tablet, what happened? There were complaints that when the school girls take these tablets, iron tablet, which were earlier sugar-coated, it leads to gastritis. So they called some people who were yes men to them, and they were told Joint Secretary, that if you give them entry-coated tablet, it will go inside the stomach and will not cause any gastritis. They forgot about it, that iron is absorbed only in the acidic medium, and that acidic medium is only in the stomach. And there are no impact of consumption of entry-coated tablets. Millions of schoolgirls were kept on giving these entry-coated tablets. I am sure that there would be some colleagues, AIIMS did this pharmacokinetic studies, absorption of from entry-coated vis-a-vis sugar coated, and we documented it in good journal and then gave it to the policymakers. And this was done in 2018, and it was stopped. It was just stopped. But again, this anti-coated tablet was costing 20 paisa. The sugar coated was costing only 9 paisa. So there was resistance from the traders, the manufacturers, because of certain realities, which are financial transactions. So it took 3 years to stop it, because the objection which was given, that what happens to these tablets when it goes into the which are in the pipeline. The orders have been placed, some are available at the district level, PSC level. So is another example. 100 milligram tablets of iron was given to the pregnant mothers. And nobody, no country in the world was giving 100 milligram of iron tablets. And these tablets were changing the microbiome of the person. And after lots of effort, after consultation, we have technical consultation, we got the best of the best brains in the country. We got it reduced from 100 milligram to 60 milligram. And as of today, only 60 milligram tablets are being given. So always remember that research is hard evidence based on the what you call true research, and then give it to the policymakers. Policymakers take time, and they have their own compulsions, but it does work. So that is what is most important, is that we must, whatever research we do, we must feed it into the program. We give it to the politicians, the bureaucrats, so that they are able to take. Next, which I talk about is, next how policy level research. Now, this is something very important. Government comes out with some policies. Who are the policymakers? Policymakers are bureaucrats. They say, we have nothing to do with technical inputs. We need hard evidence to take the policy. Fine. So what happened? Next, recently, I must salute one of the faculty member of the AIIMS, Rajkot, and he took out a beautiful article. He talked about the bias and unwarranted political view in Lancet Journal. And Lancet is one of the good journals which has a impact factor of about 8, 10, 12, I don't know. Now, this article was published. Fine, it was published and it was circulated. Now what happened? This gentleman, Krupal, he ensured that this goes to the right place, in the right politicians, right bureaucrats. Next. Now I must admire him. That the Government of India, Ministry of Health and Family Welfare made a release that, look, this is something which is a true scenario which has been depicted by Dr. Krupal. And this is something important. It made changes. It may not have worked so dramatically, but it made changes. So research is not only at the going to the grassroots level and interviewing the AIIMS, Anganwadi workers. It's basically the policy level also. Next. And my pranam to Dr. Krupal, who has really worked hard on this issue, and at least it made some difference. Next. Now, we talk about the descriptive research. We try to understand the disease burden, determinants, mechanism, and these are also important. Undertake the finding more solutions to the problem which are existing. We do not know why there is a non-compliance of anti-tuberculosis drug amongst the patients. We do not know. But still, we need to take many areas of research. Next. Now, community health studies are required. That what are the common interventions which can help in prevention control of health problems. Long time back, about 30 years back, it is waterborne diseases were being talked so much. And now you see everybody is moving, even the village level, they want to carry their own water bottles. Schools, children take their own water bottle. How come? Because there was a campaign which was launched that yes, we need to take care of our water, which is a very common source of waterborne diseases. We need to talk about we are looking at the fortifications. Everything is being fortified, rice, wheat, everything, salt, everything is being fortified. God has not made us to take pharmaceutical tablets, capsules. We have the natural foods which are available. Why can't we mix these foods? Simple thing. If even the food, if you take half a nibu and make it a little acidic and consume it, the absorption of iron increases from 4% to 16%. But we need to provide more hard data to the politicians, to the bureaucrats to take care of it. Next. Now, I'll coming to the last few slides, maybe 3 or 4. We had totally neglected our tribal population. Totally neglected. We talk about SC, ST, OBC, and so on and so forth. But look, we have 10 crore population which is tribal. They suffer from hemoglobinopathies. They're difficult to reach. What happens to the tuberculosis among them? We do not know. The tuberculosis distribution centers are far away. We have not been able to undertake this particular segment of our population. We need to look into it. Next. Now, this is a map of India which talks about the different tribal populations. Next. Now, if you look at the Gujarat, there are 5 districts which have more than 50% of scheduled tribe population. There are 4 districts which have scheduled tribe population between 25 to 50%. How much funds we are giving it to these districts for the healthcare? This needs to be looked into, and it's the academicians, it's the public health experts, which needs to go and convince our people that fine, we need to look after them. We have method how we can provide them healthcare facilities. It's not that method or strategy is required. If the doctor is posted, he needs to have some infrastructure for his own safety, his children education, so many things. But we have to give a priority to these people. Next. Now, we have epidemiology, we have public health people. We have to look for the Kala-Azar, tuberculosis, viral diseases, integrated vector management, biodiversity of vectors and parasites, development of simple tools which can do the early warning systems about the vector board. We need to develop simple diagnostic tools that, yes, these are the people, these are the diseases for which you can do it. Dengue can be done anywhere now. Corona, we had diagnostic tool, can be done anywhere. Now, issue is we need to give them a proper focus so that our primary healthcare system can improve. Next. Now, there are translation research issues that you have found out a particular thing, but you're not been able to translate into the real life situation. That's something very, very important. And we remember that because of our own efforts, we vaccinated 140 crore population in our country with COVID vaccination. It was such a wonderful effort, which all over the world it is being appreciated. Next. And we had to, in the hospital, we had to look for the healthcare associated infections, how we are able to, as a physician, we are able to deliver some of these infections to the population. This is very, very important. We have to look into simple mechanisms by which we are able to take care of healthcare associated infections. Next. With these few slides, few time which I had at my disposal, I am most grateful to all of you for giving this opportunity. And Colonel Katoch Saab, Ashwini sir, my dear friend Krupal and his colleagues, I'm really grateful to you for our patient listening. Thank you very much. Namaskar.
Ladies and gentlemen, AIIMS Rajkot extends its gratitude by presenting a token of appreciation to the speaker. May I now request Professor Dr. Colonel C.D.S. Katoch, Executive Director, AIIMS Rajkot, to kindly present a memento on behalf of the Institute. I also request Dr. Krupal Joshi to receive the memento on behalf of Dr. Umesh Kapil, sir.
Professor Kapil, is it visible?
No, the computer is visible. Yeah.
Okay. Professor Kapil, this is a small token of respect from the All India Institute Rajkot for your contribution as a whole to the academics and sparing your valuable time today for the CME. This is our memento. Please accept it and it will reach you. Thank you so much.
Thank you very much, sir. Thank you very much. It's my pleasure to be associated with AIIMS Rajkot. Thank you, Dr. Krupal. Thank you, Katoch Saab. Thank you very much.
So we are taking questions from audience now. You may post your queries in chat. And moving forward, I would like to introduce you all with our next speaker, Dr. Animesh Jain. Sir is the professor in the Department of Community Medicine at Kasturba Medical College, Bangalore. He is heading Bangalore Unit of International Chair, Bioethics and Deputy Coordinator of Medical Education Unit, KMC, Bangalore. He is a fellow of Indian Association of Preventive and Social Medicine and has received various awards. Over to you, sir, Dr. Animesh Jain.
Thank you. I hope I'm audible.
Yes, sir, you are audible.
Okay, so please give me a moment. So kindly confirm that my slides are visible. Thank you. So first of all, thanks to the administration of AIIMS Rajkot, Dr. Katoch, Dr. Ashwini, and my friend Dr. Kripal. And I also would like to say thank you to Professor Umesh Kapil, who's kind of made my job easier and also taken a few part of the things that I was thinking of speaking about. However, I am also mindful of being a little delayed in the session, so I'll try to expedite and see to it that we try and make up some time in this session. That means you on the topic given to me, importance of research and scientific methodology. And let me tell you that these ideas that I present are completely mine. They do not have anything to do with the affiliations that I carry. So with that, let me move forward. I'm sure that many times we think and we get stuck about, oh, well, I want to write a research paper. Where do I start? What do I do? I'm stuck. I'm sure that many of us have faced this at some stage in life. Now, while I'm talking about why research, why it's important, as I said, Professor Kapil has already talked about, let me take you back to some of these historical things. Now, way back in 50s and 60s, we had these rubella outbreaks, and we saw that the mothers who had this rubella during the pregnancy, they came out with offsprings or newborns who were affected, and they had congenital rubella syndrome. So much so that it came to the front page of the Life magazine as well. Now, everybody was perplexed. Quite a few people were wondering why this was happening, and somebody took upon himself to actually look into this, and this was done as a part of a research, and this was found out that yes, there is a connection. Now, moving to another specialty, dentistry, we've had different kind of crowns and materials which have been used in dentistry. Now, each material, initially it was completely of a gold metal, and then there was partial silver amalgam and other metals, and then we came out with ceramic, porcelain, other things. So if you look at even the braces that we have, they have changed. Now, how has that happened is because we thought that there could be some progress and we can make things better. And at the same time, we have to retain the qualities that we want, and we have to have the resilience and the strength that it needs to have when we are putting the braces in the mouth, and the person has to do his daily activities, including of chewing and having food. This is another example. We say that seatbelts actually save lives, but how do we know that? So there have been studies which have been conducted, and we are aware that there have been studies which have found out when the seatbelt laws were implemented and when they were followed, and how that has made difference to mortality. So these are some of the examples from our kind of day-to-day lives which are affected, and this all has been made possible, and we have progressed. We have tried to imbibe and put these things together to see to it that these are implemented in our day-to-day lives, also because we've had some evidence to prove that. And what I'm pointing towards, ladies and gentlemen, is that we need to have some kind of research which builds evidence to say that yes, this works. Or even if something doesn't work, fine, we need to have that particular evidence also there. And if it doesn't, or if it does, why does it work? So that's also important, and that is the premise of research. Now, some of us must be thinking, why research? Why everybody has to do research? To borrow from one of my friend's phrases, he says that today research, especially if we are in academics, is like something which we cannot really escape. It's like a forced arranged marriage. So if we are into academics, if we are into field of healthcare, now it's almost like everybody has to do research. And the sooner we start loving this research is better, because otherwise we don't have really a choice, and it's a kind of now become a question of survival. Yes, I do know that there are sometimes forced things don't work, and I also understand that it probably may not be a good idea because publish or perish culture is coming in. But I think we all need to have some understanding of research, even if we want to go in full time or probably only a limited aspect of it, but it's important for us. Now, with that, let me again go back to something which I want to share. So when we talk of clinical, now it's many times we say that, okay, clinically, I want to see patients, I want to do good for them. Yes, fine. But if we want to think of, and being from community medicine that we are, and preventive medicine, we think of prevention of diseases. So we say that we want to prevent diseases. Now there are multiple approaches. Which one works? How does one work? Which approach to be used in which condition? So population approach versus a high risk approach. Again, if I need to know that, I need some evidence, and that can come again from my research and epidemiology. When I say that something is a pathognomonic or something, when I say, oh, this is sure shot this. For example, apical systolic murmur means mitral agitation. How do you know? For a case series which were seen and then followed up and realized that yes, this leads to this. If I have come out with some new modality of treatment, how do I say this is better than what is already currently existing? So if I need to establish that, I need to have a study which is comparing the two. And then I say that this results in better outcomes, or less number of days of morbidity, or less post-operative care, or whatever. And when I talk about chronic diseases, say the cancers and other life threatening diseases, so I'm looking at survival. So what's the survival rate? What's the prognosis? So again, I need to look at, and that's how I can come out with that this may be the survival rate for a particular disease or a cancer. So with that, let me just briefly give you the steps in research, which I'm sure that most of the people in audience are familiar, but just to give you a quick recap. So first we start with a question or a problem that we identify. We conduct a literature review, and then we hypothesis or spell out implications. We refine our research question, if at all, and then we develop the study design. Based on this, we will list all the methods. We will go with the tools that will be used for data collection and the approvals that require to be taken for collecting that data. This we have developed our protocol, and this protocol is useful for us to put up for ethics committee approval as well as to secure some funding or grants. Once we've done that, we need to complete the research. So we need to complete data collection, then we analyze the data, and then interpret results and generate conclusions. And do we stop here? No. So we need to, of course, write report, and then I would suggest that we should make it a habit to not just present in conference, but publish, because publishing is very important. Then only it becomes something which is peer reviewed, which is going to add to the evidence, which is going to build the scientific body of evidence. And that's very, very important. So publication is important. Now, I'll just quickly take you through a few things, because I know there are sessions, but literature review is very, very important. Many times we say that, why do we do it? What's important in this? Now, literature review basically tells us what has already been done. And when we go through it, we actually get to know what has already been done, what have been the challenges. So this is the whole purpose of it. So we need to do this literature review, and this should be done as soon as we have started identifying. So this, again, if you see the problem identification, research question, then literature review is done. We formulate the objectives, we come out with the design and the methodology, get an ethics clearance, then conduct the research, analyze the data, and come out with the summary and the report and publish it. So literature review, if you see, is very early on. And why should we do it? Because it will help us to know what is already known. And it will also help us in justifying what topic we have presented or whatever research we are undertaking. At the same time, we will get the clarity on the methodology. We might also find out what has been the limitations or challenges they face so that we can overcome it better. And if required, we can modify the design to suit our research question better to be answered. So all these things are helped by doing a literature review. Just to give you two examples, if I want to conduct a study to see whether asthma education actually helps in controlling the asthma, I can do a literature review. So since I have done my thesis on asthma in pediatric age group, so I'm just taking this example. But again, if I know this, what is the current evidence, I can tailor make my research to meet that requirement or make it better. Similarly, if I'm looking at obesity and high blood pressure among the adolescents, there are multiple avenues available. I'm just showing you one. So all these can be looked at, and we can find out from not just from different populations, but also nearer home, if possible, also in our setups or in our country or our state. And if we can find some, and if we find that there is some novelty in what we are doing, that also is a helpful thing. Sometimes we might find that that's already been done. Then again, it's not necessary for us to reinvent the wheel. And this is one of the things which I would like you to look at. I'm just keeping it for a few seconds so that you can keep a note of this. So this was published in PLOS, and this is a nice paper which talks about how to go about writing a literature review. Moving on, we talked about research. Dr. Kapil also talked about it. We understand that there is a need, and we need to understand that today we talk of evidence-based practice. Now, how does evidence come in? When we are talking of evidence, the evidence has to be built, evidence has to be generated. And for that, we need research. It cannot be that my word against you. So it has to be done in a systematic way. And that's what research is. So to generate evidence, we need to do some research. And again, depending on, and Dr. Kapil already actually showed you a few, I will take you through some more, but there are different types of research. And before I go into that, let me show you something which you might have seen it earlier, but this is something known as an evidence pyramid. Now, at the base of it, if you see, if we are looking at some in vitro studies or even in terms of publications in journals. It could be editorials, opinion pieces. Then we could also have research in other species. Then comes case reports, case series, models, epidemiological studies like case control and cohort. And then one of the high evidence which comes from randomized controlled trials or randomized controlled studies. And then we synthesize based on multiple published studies, that is systematic reviews and meta-analysis. So that's the highest level. This in fact has been modified, and nowadays we also have another pyramid like this, what I'm showing you. So at the top again is systematic reviews and meta-analysis. Before that is critically appraised topics or evidence synthesis. And then we also have article synopsis, which is critically appraised individual articles, which are also looked at. So those constitute the filtered information, because what I'm doing is I'm distilling out of whatever is already there. And below, what you see is all those different types of studies, including starting from case report, case series, case cross-sectional, case control, cohort, and RCTs, which is rather unfiltered, but it's very important. And we need to look at all these. So this is what is the evidence pyramid. Now, again, to give you a brief summary, since I'm talking overall about the scientific methodology and importance of research. So if you look at what is my objective or what is my research question, based on that, I can actually take some kind of a research study or design that I can look at, and then that will help me to answer the question I'm looking at. So if I'm looking at natural history of a disease, incidence of a particular condition, or I'm looking at prognosis, I would rather go with the cohort study. I could think of a nested case control study, but best would be cohort. There is also a case cohort design which can be looked at. If I'm looking at a prevalence of a particular condition, that means I'm looking at quantifying the magnitude, I would go with a cross-sectional study. If I'm looking at causation, association, correlation, I would go with case control. However, cohort would be best, but then we know cohort has its own challenges, including the time period, including the logistics, including the funding, and sometimes a lot of problems of attrition. I'm looking at quantification of a particular vaccine or a treatment efficacy. So it's best to go with clinical trials and randomized control trials. And if I'm looking at doing that, but I feel that it's not feasible for me to do an RCT, so I might look at an alternative in terms of before-after study designs or time series designs, quasi-experimental designs. So that's what I can look at. And if I'm looking at description of certain things or cases, the characteristics, so descriptive study comes into picture or play. So with that, let me again go back to what is health research. So we're trying to generate new knowledge using, as I said, scientific methodology. And it helps us to identify and deal with health problems. Now, when we talk of health research, very, very important is the research question. The whole thing moves around or rotates around research question. So it's important for us to spend some time or a considerable amount of time and give due consideration to coming up with a good research question, because ultimately how good is my research is determined by a good research question. So when we choose a topic and a research question, it's important for me to do it diligently and carefully. Now, many times we are lost. I want to do research, but I don't know what should I do. So where do I get ideas from? So ideas come from multiple places. By searching the medical literature, I might have read something, I might have gone through a recent article, and then that triggers my curiosity. I want to do something further, or I feel that there is a gap which is there. So yes, that could be, or I attend scientific meetings, CMEs and conferences, and then some paper is presented, some speaker speaks something, or they narrate their experiences, and I might get some ideas from there. Or when I interact with my peers, colleagues, or mentors, not necessarily in my own field, but also in some different field. And why is it important for me to interact with people from another field? Because when we do that, many a times certain things suddenly come to mind. And now the world is moving towards interdisciplinary, interprofessional. So interprofessional is the way to go forward. I cannot be working in silo. I cannot be working in just a cocooned area. I need to work together. So that is again very important. Sometimes we might tailor make our projects depending on the interest of the funding research organization. If there's a call, I might tailor make my project. And if it matches my interest area, all the more better. So that can be done. Sometimes I might have done a small study or I might done a pilot project, and that leads me to develop it into a larger study. So that is also one of the ways where I can get some ideas to build on and then do a larger research. Sometimes observation. Now let me give you an idea. Long years back, one of my students said they felt that obese people had a particular way of walking, and they also, when they kept their hands on the side, they had it like a little moved towards outside, so their thumb was pointing little diagonally. Now he said that this is an observation. Of course, I'm still to follow up. I've not done that, but I remember this. And he said that this is an observation, and I want to study and compare between obese and non-obese people and whether that is really a true thing. And he said that could be one of the things which could be looked at. So observation, or sometimes even certain things work in a particular condition, so that is an observation. And many times we need to be imaginative. And when we read research papers, we need to be skeptical, we need to question things, and that may lead us to come up with new research. So these are some of the ways that we can get ideas for our research, just for people who probably are still beginning in the audience. So this may be helpful for them, I thought, and that's why I brought that. As I said, a good or poor research question will define how my research is. So it's very important for me to spend some time and make sure that my question is good. And question should be well understood, and it should be well defined. Now, you might feel that when I'm saying well understood, it's contradictory. Because if it is well understood, what's the point in doing research? So what I mean is the question should be understood. I may not have all the answers to that, but then the question should be understood. I should know how to proceed, what to measure, and how will I get an answer for that. So that's very, very important as well. So it's very important for me to spend some time, write it as a question in a proper way, and I'll show you some ways how we can do that. It should be very clear and concise. It should contain the topic that is being studied, that is the purpose of my research, the variables, and preferably the population as well. So there are three types of questions mainly: causal, descriptive, and comparative. Let me quickly run you through that as well. So causal questions basically help us to compare two or more phenomena, and we try to explore if there is a relationship existing between the two. So that is what is the causal questions role. Sometimes they are also known as relationship research questions. Like I give you an example. Does the amount of calcium in the diet of elementary school children affect the number of cavities that they have per year? So is there a relation between the calcium consumption and the number of dental cavities that students have? Or does this exposure to sun affect the grade of cataract that I have? So these are relationship. So you want to explore, and that is a causal. Or for example, does the amount of vitamin C intake lower the risk of ARMD? So all these are causal questions. Descriptive questions basically tell me about how often, how much, what is the change which has happened, and I'll give you some examples. So how often do college-age students use Twitter? Again, these are all hypothetical examples. You don't need to really think of them very seriously if you don't want to. Or I want to say that, okay, what's the prevalence of diabetic retinopathy? And again, I can specify a population, diabetics who are more than 5 years or maybe 10 years. So that becomes very specific. And I can say that, okay, I want to quantify how much. So that's again a descriptive. Comparative is between the two groups, I'm trying to examine the difference. So usually the question will begin with, what is the difference in? So what is the difference in caloric intake of high school girls and boys? So is there a difference in the first place? And if so, what is the difference? What is the difference in incidence of retinopathy or prematurity in babies born preterm compared to those who are born at term? So this is again a question which is a comparative question. So when I am trying to look at a research question, I need to define my topic. I need to narrow down and focus, and then slowly come to a question which is precisely written so that I can get an answer, and that becomes a defining thing for my whole research protocol and proposal which can be built on. So one of the ways to develop the research question is put your topic into the format of a question which can be answered by the literature. And if I can figure that out, probably that will help me to refine that further. So for example, I give you an example here. What strategies can healthcare workers use to communicate effectively with patients having a hearing disability? Now, if I figure out a few literature and then I find some answers, then I will be able to even refine further to see what works in my context or how can I make it novel or different. So there are certain criteria which I should remember. Is it interesting? Is it relevant? Is it feasible? Is it possible to progress in this? Do I have the access to data? Is literature available? And not necessarily that every time it should be available, because then we will never have a new research. So I need to also understand that with a little of a caveat in mind, that literature availability is not the only thing which I have to always look at. If it's not there, is there something related which is also available? And that's very important for me to look at as well. If not, I could be thinking and I'm convinced, then I must proceed because I may come out with something which is totally new. And is it within my resources? Is it feasible? And what benefit it will lead to others? In short, if I can give you a mnemonic, that's FINER, which was given by Hali et al. In 2001. FINER is for feasible, interesting, novel, ethical, and relevant. So this is the mnemonic, if you can remember, for writing a research question. That's very, very important. Another framework which is many times used is the PICOT framework. So PICOT again gives you a different elements, and then it also gives a lot of clarity. I'll give you an example. Before I go into that, I'll explain what is PICOT. So PICOT, P stands for patients or participants or population. So who are my participants or population or the patients? What's the intervention that I'm looking at or the indicator I'm looking at? What's my comparison or any control that I'm looking at? And what's my outcome? So ultimately, what's the outcome I will look for and within what time? So T stands for time. Now let's look at an example. I've kept it blank in the top half and then I've filled up in the bottom half to give you an example. So when I say PICOT in P, that is population or participants, does this intervention compared to a control or a whatever comparison result in a particular outcome in this time? So in our example, I'm filling up this. So in healthcare workers, what communication strategies result in more effective communication with clients with a hearing disability? And I can say that comparator is not there. So I can say that, okay, I can build in a comparator here, or I can assume that there is no need because I'm thinking of only improving that in healthcare workers. So this both ways can work. Another example I'll give you. Sometimes I can think of a description. So I can think of in the population characteristics that have to be defined because I don't want any kind of ambiguity. So that's also very, very important. And once I do that, I'm giving you 2 or 3 examples. Like, for example, I'm talking of preterm neonates, which are less than 32 weeks of gestation. And I'm looking at umbilical arterial catheter, which is used in neonates, and very low birth weight neonates, which have suspected early onset sepsis. So if I'm looking at intervention or exposure, now is the need for delayed cord clamping is done, or if I'm looking at a high umbilical artery catheter, or I'm looking at estimating the use of CRP in the first 24 hours. So any of these things can be taken up and then used in that setting. So it could be comparison could be if I'm looking at cord clamping, delayed versus immediate cord clamping, if I'm positioning the catheter high versus the low, or if I'm thinking of estimation of procalcitonin in first 24 hours versus later. So that is my control. And what's my outcome? So outcome will be again dependent on what I'm looking at, what's been my indicator or intervention. So again, if I'm looking at intraventricular hemorrhage in the first case, or I'm looking at the complications which are related to the use of umbilical artery catheterization, or it could be detection of culture proven neonatal sepsis if I'm looking at doing it early or late. So these are my outcomes. So this is how I can use that PICOT framework. So again, when I'm looking at writing my research question, I can use multiple frameworks. I can use some of these things. These are all different things which can be used to make my research question more suitable, more apt, more refined. So I can fill in the blanks. Again, this can be left for used by the participants here. Now let me take you through some of the ways where we can refine it. So if you look at this question that I'm showing you, How effective is hydroxychloroquine in the treatment of coronavirus infection? If you remember, during the coronavirus epidemic or pandemic, we had a lot of this chloroquine use. So now, if I say this and I say that I want to study this, of course, I can say that this is important because this was being used. Now, this question is too broad or vague. So I may not be able to really come out with meaningful solutions. So if I say this versus the first one, what impact would the shortage of hydroxychloroquine have on the management of coronavirus cases? Now, in this case, what I've done is I've limited it too much. It's narrowed. So the first one was too broad. The second one has become too focused or too narrow. Instead, if I put up like this, will hydroxychloroquine administration among patients that seem to be resistant or not responding to symptomatic treatment help in faster recovery of symptoms in coronavirus infection? So among the three, if you look at best choice, I'm sure that some of you might feel that this can be further refined. Yes, but just to give you an example, you see, I started with a very broad one or a vague one to a very focused one, but I said, no, that's not correct. And then I said, can I make it better? So if you look at it, this becomes much better. This becomes objective. This becomes something which I can measure and I can come out with the answers. And this could be effective even for recommending some things as well. Now that brings me to another thing. I talked about research question. There might be sometimes hypothesis. Hypothesis is basically a statement which is regarding the outcome related to any intervention that I propose. It could be an association between a factor and outcome as well. So when I say that, usually the hypothesis will be predictive. And usually when we use this is usually used when we have some knowledge base already. We already have some information, so we know something about it. I cannot go for something which is totally unknown. And hypothesis is always written as a statement. Before I start data collection, I need to develop my hypothesis. I'm giving you an example as well. So if I say that I institute a wellness program in a particular company, and I say that just because I do that, it will decrease the number of sick days leave that the employees claim. So that's my hypothesis. So I say that, okay, if I put up this program, this will lead to less number of sick days of leave that the employees claim. Or consuming vitamin C supplements will reduce the incidence of common cold in teenagers. So this is my hypothesis. It need not necessarily be true. However, when I go through my research, collect data, analyze, and find the results, I might be able to prove or disprove this. So that is the idea of hypothesis. That brings me to objectives. Now, objectives, please remember, SMART is the mantra. That means it should be specific, it should be measurable, it should be achievable, relevant, and time-bound. So this is very important. So when I propose a research question, a hypothesis, and then come out with the objectives, I need to remember to have this in mind. So how do we go about research question? Find an issue that interests me. Then I need to look at more and more about it and what I want to do about that specific issue, turn it into a query or a specific question, and then figure that out that the question should be answerable and it should not be too broad or narrow. Now, I talked about publication initially, so let me take you through why it's important for me to publish as well. Why is it important to write? So, of course, it gives me fame, recognition, but other than that, it's also important as a responsibility. If I am doing something, it is important as a responsibility, whether it's funded or unfunded, I must do that because it helps in progress of science, it builds evidence, as I told you. It's also a regulatory requirement to promote incentives. And if I have taken a grant, definitely my grant or funding agency expects me to publish. And that will also help me to get more funding as well. And since I'm getting a grant, and if I'm getting it from a government agency, it's the taxpayers' money. So again, I'm accountable. So I must do that. And as I said, it is also contributing to progress. I'll give you some examples of some of our published research in the last couple of years. So this was during the COVID times. We looked at perception and practice regarding infection control measures in radiology department during pre-COVID and COVID times. And we looked at also the concepts and literature and did that. Malaria has been a big problem in Bangalore for a long time. Of course, post-COVID, we're not seeing so many cases. So we looked at digitizing the whole surveillance system and looking at how it works. So 5-year analysis we did post digitization, and then we published that. We initially published when we actually started with the GI, that is Geographical Information System tagged tablets for this, and this was the first paper, and 5 years later we came up with this. So this is again something which we looked at, and this is also building evidence. So does this work? And if it works, how is it working? So all that. Then there was something about, again, malaria, that how exactly this indoor residual spraying working, and a case control study was instituted. We also looked at what is the distribution, so hot pops, and we looked at how and where the cases were concentrated, were clustered. So we looked at that. And this was another thing which we tried in the curriculum. One of the fellowship program that I'm actually currently right now also at FAMER program at Manipal. So one of the fellows, Nandita, dentist by profession, she wanted to include practice management education in dental curriculum and how it actually helps. So we tried to bring in that because this is not a part of the curriculum. So this was also brought in. Or again, in the context of teaching, learning, and scholarship, we looked at communication skills training and how it helps to build empathy. So these are some of the things that we've tried out. This was not our paper, but again, this is important because once you see something different, so KFD or carcinal forest disease has traditionally been confined to Karnataka, but then the first reported case in Kerala was reported, and then they said that this is the first case. Now it is important so that that also is known that there is a possibility that it can be seen there, and then people get sensitized. So it is important for us to know that as well. And this is another paper from KFD. Here, if you look at, usually it leads to different symptoms, but previous literature here suggested that there was no signs of language deficit. But in this particular case, they have reported a case of 5-year-old child who had KFD and diffuse encephalopathy, so also had some kind of language deficit, and that is also reported. So these are important things which we need to report. Again, the health seeking behavior, promotion practices, so comparison, so that helps. So again, just to show you. Now I'll take the last bit towards AI. Now AI is a big thing. Everybody is using ChatGPT and whatnot, Research Rabbit and whatnot on perplexity.ai. So can we use it for academic writing, for research? Ethically, if we use, judiciously we use, it's fine. And my views are that going forward, that is going to be there. It's going to be the future, and it's here to stay. So we cannot deny it, but we need to use it responsibly. And if I'm using it, I have to take the responsibility. AI cannot. So in fact, there have been reports, they say that it's, and it may be now 2000 as well, I'm not sure, this is a little dated, few months back. So 1000 more or more publications by ChatGPT. So what they say is, when I'm using any of the AI engines, I need to disclose how it's been used. I cannot make them an author, but I need to disclose both my cover letter as well as my methodology has to mention what has been used and how it has been used. And of course, I cannot list it as an author because they are not going to be accountable. They are not responsible. So ultimately, it's the technology in the hands of human beings, and human beings have to take the responsibility. So we need to remember that and make sure that whatever we submit, we take responsibility, including in case there has been a goof up or hallucination or a plagiarism by the AI, I need to take responsibility. And that's why it becomes more importantly my double responsibility to see to it that ensure that it's not there and declare that as well. Many of the journals have started changing their policies, so that's important. And this is one algorithm I found in UNESCO guidance booklet. It said that if you're using ChatGPT, or for that matter any AI, so look at whether it is safe or not. So when you do that, how important is it for you to see to it that the output is true? If it's not important that it's true or not, continue using safely. But if you feel that it's important for you to have the output which is true, so do you have the expertise to verify it? If yes, are you able and willing to take the responsibility, both legal, moral, etc., for anything which can happen because of the inaccuracy? So if yes, please go ahead. If not, and if you don't have the expertise, please use it with caution, or rather don't use it. So this is a good guidelines. And again, no endorsement, but this is one person I follow on Twitter, and I feel that a lot of insights I'm getting into about AI and how to use it, and responsibly as well as in judicious way, as well as in a nice way. So please remember, AI is here to stay. we cannot deny, we cannot escape it. The best way would be to adapt and use technology, but please be mindful of judicious and ethical use of it. And I would also remind you of the ICMR guidelines. So any research which is done in India must follow these guidelines, which are available freely as a PDF document. So it's important for us to stay within the confines of ethics guidelines. And finally, one of my favorites again, productive stupidity. So the importance of stupidity in scientific research. Some of you must be wondering why I'm talking about stupidity when I'm talking about scientific methodology. So sometimes we don't get the desired results, or sometimes we fail. It's okay. It's important to know that everything doesn't happen the way we might assume or may wish to. That's okay. So what we need to understand is every time we get the results, whether it's in line with what we expected or not, we should learn and we should move forward. And that's very important. So productive stupidity means being ignorant by choice, but at the same time learning as we go along. And that's very, very important. These are some of the important websites for us to know more about certain things. So International Committee of Medical Journal Editors, and I would suggest that everybody who's planning to be a researcher should and planning to publish should have a ORCID ID. It just takes a few minutes to just register yourself. So please do that and have a Google Scholar which profile and a ResearchGate profile. It helps. And with that, let me end. I would like to again emphasize research is important. At the same time, scientific rigor and methodology needs to be followed to make this research which is foolproof and which contributes to evidence. Careful consideration must be given while starting any research, and we have to come out with a good research question. With that, I would like to end. And as I said, I have tried to cover some time, but then again, that's the best I could do. So thank you.
May I now request Dr. CME ma'am to present the memento on behalf of the institute. I also request Dr. Mehul sir to receive the memento on behalf of Dr. AIIMS.
I think fully sir.
Thank you. Thank you so much.
Now, I invite our next speaker, Dr. Rajkot Devnath. Sir is an additional professor in the Department of Community and Family Medicine in Mangalgiri. He has an MD and PhD in Community and Family Medicine from BJMC Pune. He was selected amongst top 5 best practices in the country in field category 2023-24. Co-chairperson of IAPSM position paper, member secretary of IAPSM Best Practices Committee, and associate editor of IAPSM Best Practices Comparing. Over to you, sir, Dr. Rajkot Devnath.
Thank you so much. Good afternoon, all. Respected Executive Director, sir, of AIIMS Rajkot, sir, Dean Research Madam, Dr. Krupal, and the entire organizing team of this national CME, I am extremely thankful for giving me this opportunity. I would like to share my PPT. Can you give the permission to share the slides?
You have, sir. You can share.
Are the slides visible?
Not yet, sir.
Now are they visible?
Yes, kindly make the presentation mode.
Yes.
Yes.
Okay.
Yes, sir.
So what is the need for this effective research strategies and design? So it is basically to ensure that our studies are very robustly built, are reproducible, they generate results that are valid and are reliable. Now let us look at the broad research strategies. So this can be divided into quantitative research and qualitative research. So coming to the quantitative research, so it follows a deductive approach We mainly do it to either prove or disprove the hypothesis. In this type of research, the sample size is calculated by a mathematical calculation, and we have the statistical, numerical, and quantitative aspects of the phenomena of interest. And what we are concerned about is the internal validity, external validity, reliability, and objectivity. Whereas if we look at the qualitative research, it follows an inductive approach. It is mainly done to develop a hypothesis. The sample size here depends on the theoretical saturation. Data is collected using in-depth interviews, focus groups, and observation. And what we are concerned here about is the credibility, transferability, dependability, and conformability. Now let us look into the various study design which we use in quantitative studies. Now the most important thing is we have to look at who assigned the exposure. Did the investigator assign the exposure? If yes, it becomes an interventional study. Then in interventional study, we look at whether there was random allocation done. If yes, it becomes a randomized controlled trial. If there is a no random allocation, then it becomes a non-randomized controlled trial. It becomes an observational study. Now we look at whether there is a comparison group. If there is a comparison group present, it becomes an analytical study. Now we look at the direction. So
Sir, your
if we
volume
follow
cover.
from exposure to outcome,
Hello,
it becomes a
sir.
call study. The outcome has
Uh,
already occurred.
sir,
The participant to
excuse me, sir.
recall their exposure.
Excuse me, sir.
It becomes a misconduct study. And in
Uh,
I am not audible? I can hear you.
yeah, sir.
I can
You're
hear you. I
audible,
can hear
but
you.
voice is cutting. No, slide is perfectly fine. If possible, no, due to network, kindly switch off your video because voice is cutting, sir.
Switch off. Okay, I'll switch off the video.
Yes, sir.
Yeah,
It may improve
yeah.
your voice.
Network is
Yes,
a little unstable.
yes, yes, sir. Yes, sir.
Yes.
Yeah. Now makes presentation mode.
Just let me know if I'm not audible. Please.
Yes, yes, yes. Sure, sir. Sure, sir.
Yes.
Yes, sir. Please continue.
So if the outcome and exposure have occurred at the thank you. If the outcome and exposure have occurred at the same point of time, it becomes a cross-sectional study. And if there is no comparison group in an observational study, it becomes a descriptive study, and it can be done on individual or the populations. And these are some of the alternative names which can be assigned to this cross-sectional studies, can also called as prevalence studies. So what are the key factors in choosing a study design? So basically, we have to look at what is our research question, resources, timing, the funding, research expertise, study population, data availability, and ethical consideration. Now, first question: what is the prevalence of severe acute malnutrition in under 5 children in a village? Second is care clinic. Third is what is the survival in HIV infected males and females and the factors associated with survival? Fourth question is what are the risk factors of Kaposi sarcoma? Fifth is what is the incidence of cardiovascular events in patients with psoriasis over a period of 10 years?
Sir, your volume is very cutting. Hello. Dipnath sir. Hello. Hello. Dipnath sir. Excuse me, sir.
We would consider that the cross-sectional study would be an optimal design because we want to look at
Excuse me, sir. Dipnath sir. Yes. Maybe he has left. Sir.
Can you hear me?
Yes, sir. If possible, you can save the presentation here. We'll do from this side also, sir. Voice was very low, sir.
I changed the internet connection now. Is it
Yeah, now it's
audible?
clear, sir. Now it's a bit clear, sir. Yes, sir. Please, sir.
I changed the connection. Yeah. Thank you,
Yes,
sir.
sir. Please, sir. Please,
Sorry
sir.
for the interruption.
No. Please, sir. Please.
Yeah. So,
Yes, please continue, sir.
Yeah, thank you. What is the survival in HIV infected males and females and the factors associated with the survival? So for this type of study, research question, we can follow the cohort study. We can. Next is, what are the risk factors of Kaposi sarcoma? Now we all know that Kaposi sarcoma is a condition which is very rare worldwide. And as per the data, it is only 1.53 per 1 lakh person years, the incidence of Kaposi sarcoma. For such type of study, we can have this study design, which is case control study. And this type of research question, like what is the incidence of cardiovascular events in patients with psoriasis over a period of 10 years? We can have a prospective cohort study design. Now, this already discussed the previous lecture. It has been already covered the evidence pyramid. Now, there is a slightly proposed, this is a slightly changed. This is the newly proposed evidence-based medicine pyramid, where it is not the straight lines, where we look at here, it is a curvy lines are there. And it is said that this is based on the grade approach. So when we look at this curve, we can see that a well-conducted case control study can be better than a poorly conducted cohort study. So this is the newly proposed model. Coming to the types of descriptive studies, this can be case reports, case series, cross-section studies, and ecological studies. Case reports, here a single case is presented in details. It can be mainly new disease, or it can be unfamiliar disease, or it can be a rare manifestation of a disease. And this can be used to generate hypothesis. Coming to case series, now this involves a larger group of patients, that is more than 10 with a specific disease. And we can put up the clinical picture of a disease, but there is no comparison group here. And coming to descriptive cross-sectional surveys. So here, observation of the population at a single point in time. The individual is the unit of observation and analysis, and it collects the information about disease burdens, and also known as the prevalence studies. Now, in descriptive cross-sectional surveys, we can recruit the study participant from the population or take the sample of the population, and we can observe for one or more outcomes and one or more exposure. So this is the advantage of cross-sectional surveys. We can look for one or more outcome at the same time. We can look for one or more exposure also. Coming to the uses, it can estimate the prevalence of disease or the risk factors. We can find out the distribution of health problem by time, place, and person. It is helpful for setting priorities for disease control, and it can plan the delivery of healthcare services, and it can be used to generate hypotheses and examine evolving trends. Now, such type of research questions can be addressed by descriptive studies. Am I clear and audible? Hello? Am I audible?
Yes, sir, you are audible.
Okay, thank you. What is the prevalence of diabetes among cigarette smoker, or how satisfied are patients attending primary health care center with AIIMS treatment facility? What is the prevalence of depression among college students? Such type of research questions can be answered by descriptive cross-section studies. Coming to ecological studies, here unit of analysis are not individuals, but they are groups. No individual level information is there on the distribution of exposure in such type of studies. And it relates the population with high rates of disease, also have a high presence of suspected risk factor or the exposure. Now, moving to analytical studies, here exposure is not assigned by the investigator, and but we have a comparison group, and it measures the patterns of exposure and disease in population and makes inference about risk factor or exposure and the disease. Coming to next step is, in this there are 3 types. So we are now discussing the first one, that is analytical cross-sectional studies. So as I said earlier, here the exposure and outcome are measured at the same point of time. The comparison group is present, but as such controls are absent. So because the exposure and outcome are measured at same time, there is a difficulty to establish the temporal association, because the time sequence cannot be established, which came first. And it is also prone to prevalence incidence bias, also called as the Niemann bias. But the good thing is, we don't have any attrition bias here, that is loss to follow-up is not there. Advantages of cross-sectional studies: it is fairly quick and easy to perform, less costly. Coming to the limitations of cross-sectional survey, so it is not useful to study disease etiology. It is not suitable for study of rare diseases. It can study only prevalent cases, that is both old and new case. And exposure and outcome can be examined at the same time. So case reports and case series are used to publish the rare or clinical features. Ecological studies can be used to relate group level data and hypotheses. And cross-sectional surveys help to measure the disease burden or magnitude of a health condition. So coming to next type of study is cohort study. So cohort basically defined as a group of people who share some common characteristic. This is schematic representation of a cohort study. So we have a population from where we go on to select a cohort which is exposed to a certain risk factor, and another cohort which is non-exposed to a risk factor. And then we follow up this population in time to see who have developed the disease and who have remained free of disease. And then we calculate the incidence among exposed and incidence among non-exposed. So here we measure the strength of association by RR, that is relative risk. So this is another schematic diagram. So there are basically again 3 types of cohort studies. In the prospective study, the exposure occurs after the study starts. And then we follow up the population, the 2 cohorts for the development of disease. In ambidextrous, the exposure has occurred, the study starts after that, and then again the patients, the cohort are followed up to know whether they develop the disease or not. And in retrospective cohort study, both the exposure and disease have occurred, but we go back in time, and if we have some good records, we look at the exposure and follow the population in time to see which cohort developed how much incidence of disease. So elements of cohort study. So first we have to select the study population, gather the baseline information, follow up and do the analysis. Selection of study population can be from the general population cohorts or a subset of it. And sometimes we may take some special exposure cohorts like occupational groups, especially if we want to study some, suppose, instead of some cancer in certain occupation, then we can have this special exposure cohort. So we have to gather the baseline information, which depends on the study objective. And very important to have a valid assessment of exposure status of the members of cohort. So exposure status assessment is very important. It should be properly done. Then have a identification data, and individuals with disease are excluded at the baseline. The sources of baseline information can be existing records. This can be from hospital records or employment records. We can have interviews, either personal or questionnaire can be mailed to the participants, and clinical examination can be done. And also we can have measurement of environment, that is air pollution or exposure to any particular chemical, etc. The most important thing is to follow up these individuals, the cohort, to see whether the outcome of interest has developed or not. And it is again very important to have uniform and complete follow-up of all the cohort members. But the most problem in this studies, cohort study, is the attrition bias, because such studies are done over a long period. So people may leave their place where they stay, and it can lead to attrition bias, which can influence the study validity. Also important to have uniform surveillance in exposed and unexposed group, and to have a complete ascertainment of exposure and outcome. And there should be standardized diagnosis of outcome events, which should be clearly stated and defined. Now, when we look at this table, so when we start this cohort study, what is known is exposed and unexposed, that is A plus B. What is marked in red color is that what we know at the start of the study. That is, we know who are exposed and who are not exposed, that is C plus D. And then we follow up in time to see how many got the disease among exposed and how many got the disease among unexposed. So for calculating the strength of association in cohort study, we calculate the relative risk, which is given by the formula incidence of disease in exposed, that is A upon A plus B, and divided by incidence of disease in unexposed, that is C upon C plus D. Now coming to the interpretation of RR. So if RR is equal to 1, so incidence in exposed and unexposed is same. Here we know that exposure is not associated with the disease. Now if RR is more than 1, it shows that incidence is exposed is higher than that of unexposed, and exposure is positively associated with the outcome of interest. And if RR is less than 1, that means incidence in exposed is lower than unexposed, and exposure is really protective if RR is less than 1. Coming to the strengths of cohort study. So here multiple outcomes for a single exposure can be studied, and it allows calculation of incidence since we are following up the population in time. And important thing, temporal sequence can be here because we have started from the exposure and we are going to see whether the outcome of interest has occurred or not. And another important thing is it can be done for rare exposures. Coming to the weakness of cohort study. So it is very time-consuming process because following of the cohort for a long period of time, lot of time is taken, high cost involved. There can be attrition bias because of the loss to follow-up. And then it is not good for conditions with long latency period. coming to case control study design. This is a schematic representation. So what is important here is the outcome of interest has already occurred. And we have to ask those cases, and we take controls where the outcome has not occurred, and we ask them about their exposure of the risk factor. Now in this study, we try to see the association between smoking and lung cancer. So we take the cases who have already got lung cancer, and we ask them with, about the smoking history. And controls, we take those who have not suffered from, those who are not having lung cancer. And to control also, we'll ask about the smoking history. And then we will calculate the odds ratio, which will give us the strength of association for a case control study. So elements of case control study: selection of cases, selection of controls, information on the exposure, and then doing the analysis. So selection of cases can be from the people in source population who develop the condition of interest. You can take the sample of cases, and it should be independent of the exposure under study. Very important to have a clear definition of outcome. But during this process, there is a bias called as prevalence versus incidence bias can be there. Because what we see is that, suppose we take an example, acute myocardial infarction. So here prevalent cases may be more related to the survival with the disease rather than the development of the disease. Because what happens sometimes is that if the person gets a severe AMI and the persons die within 1 to 2 hours before taking him to the hospital, in such cases, these cases will be missed out because we are taking only the prevalent cases. So it can introduce a bias in the study because we are missing out the cases who had severe AMI and who could not be included because they have died before they reached hospital. So we have to be careful while interpreting the results. Sources of cases can be hospital or clinic based, which are more easier to find, but may represent again the severe cases, or it can be drawn from the population also. These are not biased by factors drawing a particular patient to a particular hospital. Selection of controls. Now, controls should be without the outcome of interest. They can be selected from the same source population that gave rise to cases, and they should be selected independently of their exposure status. Controls can be selected by sampling of the general population, or we can take from a hospital, that is patients who are suffering from other disease. And it can be also taken from the case-based neighbors and friends. So important thing is, or most challenging thing is to gather data on exposure, because exposure might have happened several years ago. So it should be done objectively and very precisely, and there should be quality management in exposure measurement. Now this table shows, so what we know at the start of the study is A plus C and B plus D, that is cases and the controls. And we ask them by recall method, how much was the exposure in the cases and the controls. And in this odds ratio will give us the strength of association, which is calculated as AD by BC. Now coming to the interpretation of odds ratio. So if OR is equal to 1, that means odds of exposure among cases and controls are the same. If OR is more than 1, that is odds of exposure among cases are higher than controls. And OR is less than 1 is odds of exposure among cases are lower than controls. So come to the strengths of case control study. So it is quick to conduct, so less costly as compared to other studies, especially cohort studies. And it is very good for studying rare outcomes. Also good for studying conditions with long latency period, and multiple exposures or risk factors can be studied and requires comparatively few subjects. Coming to the weakness of case control study. So recall bias is a major problem. Incidence cannot be calculated. Control may be challenging, and multiple outcomes cannot be studied. Now this table shows the applications of different observational study designs. So when we see here that for investigation of rare disease, you can go for the case control or ecological studies. For study of multiple exposures, you can have a case control study. To measure time relationship, you can have a cohort study. To measure incidence, we can have a cohort study, and to investigate long latent periods, you can go for a case control study. So the advantage and disadvantages of different study designs. So in you can see here in case control study, the recall bias and selection bias is high as compared to cohort study where it is low. Whereas in cohort study, the loss to follow-up or attrition bias is high, and time required is high in cohort study, and cost is also high in cohort study. Now coming to clinical trials, so again very important component. So here the results of basic scientific research are translated into better ways to prevent, diagnose, or to treat disease. Now, clinical trials involve volunteers and are designed to answer scientific questions and find better ways to prevent, diagnose, or treat disease. So it is a planned experimental study, can be used to assess the efficacy of prophylactic, diagnostic, or therapeutic agents, device, procedures, etc. And it is done on human beings. So we have to be very careful while conducting RCTs because there are ethical issues involved here. Now in randomized controlled clinical trials, we compare the outcomes in a group of patients treated with a test treatment and compare with those in a control group of patients whom we give usually standard treatment or old treatment, and they're enrolled in a prospective study and followed up for the same period. So the objectives of clinical trials are to evaluate new forms of therapy or prevention methods, new drugs or treatment, new healthcare technology, new healthcare delivery system, new methods of primary prevention, or new programs of screening or early detection.
Yes.
This is schematic.
Respected sir, we are running out of time. Please.
Sir, only 2 minutes, sir.
Yeah.
I'm just ending.
Okay, okay, yes, 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 sir, yes.
So this is a schematic representation of a RCT. So we have a population suffering from disease condition from where we take the sample and randomize into two groups. One group is given the new treatment which we want to test. Another group is given the standard treatment, and then there is periodic follow-up. And then we see how many have been cured or not cured in both the groups. So randomization is very important in this, which ensures comparability between the two groups. And it is the only condition which can prevent the selection bias. So here one group gets the most widely accepted treatment, and the other gets the newly treatment that is being tested. And so the confounding bias is minimized here because of randomization. You can also go for blinding, single blind, double blind, and triple blind. And blinding helps to eliminate the co-intervention or biased outcome ascertainment. These are the 4 phases: phase 1, 2, 3, 4. Starting with phase 1 is mainly to deal with safety and acceptability, where we start with only about 50 or so healthy volunteers. Then we move to phase 2 to look for the long-term safety, dose and schedule, and early indications of efficacy. Phase 3 is for the effectiveness, and phase 4 is to see for the post-marketing surveillance, which is community-based. So advantage of RCT, it is the only effective method which can control selection bias. It controls confounding bias without adjustment, which is important. And you can do blinding and maintains all the advantages of cost study. Disadvantages, it is complex and expensive. It lacks representativeness because volunteers may differ from the actual population of interest, and ethical challenges can be immense. Suppose now we can't do a RCT to prove the lung cancer and smoking hypothesis because we can't assign a group that you smoke and the other group does not smoke, because we know already that smoking causes lung cancer. So such type of challenges are immense in connecting the RCTs. With this, I thank you for giving me this opportunity. Thank you, AIIMS Rajkot, administration, director, sir, and the entire team.
Thank you so much, sir. May I now request Dr. Vivek Kumar Sharma, sir, to present the memento on behalf of the institute. I also request Dr. Akshat Gupta to receive it on behalf of Dr. Devnath.
I'm thankful for this.
So moving forward, it's a great privilege to introduce our next speaker, Dr. Ayushman Mohapatra. Dr. Ayushman is an executive director of Grid Council India. He has received an appreciation award from the National
Rajkot team, not audible, please. Hello. You're not audible, Rajkot. AIIMS Rajkot. Rajkot, please.
Team,
Yes,
yes,
yeah,
can't hear you.
yeah.
Yeah, can I get started or like?
Rajkot team, you're not audible, please.
Am I audible, Dr.
Yes,
Rathod?
yes, sir. You are audible perfectly. Yes.
Right, so let's get started. I think it was production that has just gone by. So thank you, AIIMS Rajkot. Thank you, Eco India, for this opportunity to interact with this audience. I'm Archasman Mahapatra, and I shall be talking about. I've been given this topic to discuss descriptive study designs, and I expect my audience to be as interactive as possible. I'm keeping a track of the chat window as well. So if you have any queries, do write into the chat window. Let's interact. I'm also thankful to Dr. Dhrubajyoti Devnath, my preceding speaker, who has covered all the study designs and has already spoken in details. So please excuse me if some of my slides look a bit repetitive. Suppose I'm like it's too boring and it gets too repetitive, let me know so that I could skip also. I have a PPT deck and I'd like to share it with you all.
Please, sir, you can.
Just confirm it is on.
Yes,
Yeah.
yes, yes.
Okay, thank you.
Yeah,
Thank you.
it's visible.
Is it?
Yes.
Fantastic. Thank you. So this topic relates to descriptive study designs. And I would go a bit beyond this because it's very restrictive if I limit my entire discourse to just descriptive designs and not consider how these fit into the bigger picture of observational designs at least. My scheme of presentation would be, I'd be having an introduction, which will mostly be as I speak. And then we'll be talking about observational study designs. I'll be talking about descriptive designs as well as analytical observational designs, and then a bit of commentary. Let's relate back to whatever experiences we have. As I said, the chat window is open. I shall also share some of my experiences as we discuss. I understand that I have about 45 minutes. Just correct me if I need to close by 4:45 or I can extend till 5 o'clock. Organizers?
Yes, sir. Yes, sir.
Okay.
Yes.
So what do I do? Should I keep it to 30 minutes or and help you catch up with time, or should I go until 5 o'clock? 45 minutes.
Need to get connect with Rajkot team also. We'll get back to you, sir. Please, you can start.
Okay. Okay. Thank
Yes.
you. So this is a traditional classification of study designs. We are quite acquainted with it, and if you're not, still, I'll walk you through this. Broadly, study designs can be classified into two mindsets. One, where we just plain describe a story. We either tell a story or we tell some stories together. The other one is the analytical design, where we try to see relationships between variables. It is quite traditional to say that descriptive designs generate hypotheses, while, okay, thank you. Descriptive designs generate hypotheses, while analytical designs help us in testing hypotheses. I would mostly agree with this statement, though I must also mention that many times researchers do have a hypothesis. So the differentiating factor is not that you whether have a hypothesis or don't have a hypothesis, but whether you want to test a hypothesis or not test a hypothesis. Yes, Dr. Munazza, I think we can't take audio queries. You can write it in the chat window if you have anything. Okay. Now, or do we take queries in between? Organizers, can you just give me a heads up? We can in window. I'll close down 5 minutes before time so that we can take some questions at the end of the session.
Yes, sir. Please.
Right. Okay, thank you, Dr. Arto. Now, if we look at the left side of your panel, look at the left side of the panel, we get descriptive designs, and we have all heard about it: case reports, case series, cross-sectional designs, and ecological designs. Now focus on the analytical designs. If you are just observing and not exactly intervening actively, you're just observing, then in the observational classification, you'll get again cross-sectional designs, ecological designs, case control, and cohort. By now, you should have noticed that you find cross-sectional designs on both sides. So cross-sectional designs and ecological designs in the descriptive side as well as in the observational side. I must confess that this classification or any classification of study design is an oversimplification. These are along a continuum. These designs are along a continuum. And if we look at them logically, we'll gradually realize that that's how research possibly would have evolved. The research community would have possibly evolved. And increasingly, the complexity of study designs have been appreciated. I would not talk about the randomized controlled trials or quasi-experimental designs. These have been covered in the previous session. And also these are experimental designs where the researcher intervenes. Broadly, just to keep things simple, if we are randomizing participants into groups and there is a test group and a control group, and it's a trial, that means it's an experiment where the researcher is actively intervening, then it is a RCT. Any other format of trial or experimental design, which either does not have a randomization, does not have a control group, or is just a simple crossover sort of a design or a time series design, you can classify them as quasi-experimental design. So quasi-experimental means very close to experimental, almost like an experimental design, but not exactly a RCT. Now, if we want to know more about these studies, like a case report, that means a single case very nicely described. A case series, that means a group of cases described and some commonality discussed, or a cross-sectional survey, or an ecological design. I'll be talking about these designs in details as we go further into this presentation. Each of it is a very powerful method. Each of it is a very powerful design in itself, if done very nicely. Now, the medical journal editors across the world found that whenever researchers would report or write a paper, there were inconsistencies. I'll take the questions towards them. So there are inconsistencies in the way they write a manuscript. So what they have done is, they have all come together and provided guidelines. Use the website, equata-network.org. On this website, you will find all the checklists referring to different types of study designs. For example, if you're talking about observational designs, then we have SPROBE checklist, systematic reviews, we have the PRISMA. For randomized trials, we have CONSORT. So these are quite common checklists that we use for reporting. These are actually guidelines, reporting guidelines. So what you get is a PDF or a Word format of all the checklisted items, as well as an explanation and elaboration paper. That's a detailed paper which explains each element of the checklist. I would strongly recommend students of epidemiology, public health, or any format of research to access this website, Google up, and find the E&E papers, explanation and elaboration papers. No textbook will beat these papers. If you read these papers, you will have very foundational understanding of each study design and the beauty of these designs. Right. Now let's look at the hierarchy of evidence. This again is commonplace, where whichever textbook you open up, they will, whichever textbook of research designs you open up will have this pyramid. And they usually place, this again, I must say, is an oversimplification. Ideas, opinions, editorials, or just anecdotes form the base of the pyramid. These are not considered as very robust evidence. But as you go up, you will find case reports and case series. Further up, cross-sectional designs, case control designs, cohort designs, then RCTs, and systematic reviews and meta-analysis. Now science has evolved further. We have hybrid designs, we have implementation science, we have a combination of that is mixed. Those are adding more pragmatic evidence, actionable evidence. But look at this pyramid, and you'll see observational design. So even if this pyramid puts things on a hierarchy, we must realize that a very nicely done cross-sectional study could actually beat a poorly done case control study. So it's about the robustness, the quality of the studies that inform the nature of evidence and subsequent action based on these evidence. So the practice of evidence-based medicine cannot be just relied on the fact that the evidence has come from a RCT. It could be a badly done, biased RCT, but a fantastic case control or a fantastic cross-section study or even a case report could change the world. Hence, much of the grading of evidence that is being done these days has layers to it. If you could see this grading of evidence, the topmost is again systematic reviews and meta-analysis of RCTs. So you'll find systematic reviews and meta-analysis of observational studies as well. But here, systematic reviews and meta-analysis of RCTs is considered as sacrosanct. And then further down, 1B, if you look, at least one nicely conducted RCT. Or 2A, at least one well-designed study, well-designed control study, it's okay not to be randomized. So if you look at this kind of a grading that has happened, people are increasingly realizing that it's not just the study design, but the quality of evidence and how it is being reported that are important. Now, let's go back to the previous slide. This one, or even this one. Here you will find that the study designs are becoming increasingly complex as you move up. And this is also reflecting in the pyramid that we saw. Recently, we experienced the COVID-19 pandemic. I would play a video. And I think you will be able to appreciate how research evidence has evolved through this particular experience, how a case report went into a case series, went into almost a case control, and then a cohort. Not in the typical way, but that is how nature has operated in the way we have looked at evidence. Let me know if this video is audible to you. Is this video audible?
Yes, audible, sir. Audible, sir.
Perfect, thank you.
Of Wuhan. It is home to an estimated 11 million people in eastern China. It is here where health officials believe the new coronavirus originated and eventually spread across the globe. Cases of the disease it causes, known as COVID-19, have risen rapidly as health officials have worked to contain the virus. Here's how COVID-19 became a global pandemic. On December 1st, 2019, a patient in Wuhan begins to show symptoms of viral pneumonia, according to a report in the Lancet Medical Journal. That patient is believed to be the first documented case of the virus. Throughout the month, a series of pneumonia cases of unknown cause emerge in Wuhan. Symptoms include a fever, labored breathing, and a dry cough. At the end of the month, the Chinese government informs the World Health Organization of a cluster of pneumonia cases in Wuhan. Between December 31st and January 3rd, a total of 44 cases are reported to the WHO. Many of the patients were found to have visited an open-air seafood and animal market within the city. Chinese authorities shut down the market, and on January 5th, the WHO reports the infection could be connected to exposure to live animals. Chinese scientists discover sick patients are infected with a new strain of coronavirus, according to Chinese state media. Coronaviruses are a large family of viruses that include the common cold. At this point, there are no documented instances of human-to-human transmission. On January 11th, China reports the first death from the disease in Wuhan. Concerns grow about the ability to contain the virus over the upcoming Chinese Lunar New Year, when millions of people travel across the country. Wuhan is connected to other major Chinese cities by nearly 22,000 miles of high-speed rail, and connected to the world via an international airport that transports 24.5 million passengers a year and connects to 30 cities around the globe. A Chinese tourist traveling from the Wuhan area is found to have a fever after arriving at the airport in Bangkok, Thailand. On January 13th, This person is confirmed to have the first case of the new coronavirus outside of mainland China. Over the next week, cases appear across Asia and in the United States as well. According to the WHO, on January 23rd, there are 581 confirmed cases globally. As health officials announced the virus can spread between humans, the Chinese government cuts train and air travel out of Wuhan, effectively quarantining the entire city in an effort to contain the spread. With over 7,800 confirmed cases, the WHO declares the coronavirus a global public health emergency, indicating authorities believe the virus is a significant threat beyond China. In Yokohama, Japan, passengers aboard the Diamond Princess cruise liner are quarantined. For almost 3 weeks, passengers are confined to the ship as they are tested for the virus. 696 people on the ship are ultimately confirmed to be infected, including some Americans. A week later, the WHO officially names the disease COVID-19. The name.
Right. So let's have some interaction with the audience. I'll just quickly recap what you just heard. On 1st of December, a report is, so there is a reference to a report published in the Lancet, which says that on 1st of December, a lady reported with symptoms of pneumonia. What is this design? Yes, there's a raised hand from research cell. What is this design? You can type in the chat window as well. Case report, fantastic. So this was unusual. One woman reports with pneumonia and very difficult to treat. All antibiotics have been tested on that woman and nothing has worked. Fantastic. That's a case report. It must have flown like a single person's story. Now they say that over the next couple of weeks, many such cases were reported. What is that about then? Case series. And now, when they look at the series of these cases, they are able to say, okay, this is the presentation of this disease. This is how the disease presents. It presents with ARI, or it presents like influenza-like illness. Some of them may get admitted. SARI, severe acute respiratory illness. Over the next few weeks, some 600 or 344 cases were reported. What could have that been? It is like a population under surveillance. So they did a cross-sectional and they found that as many cases. Yes, cross-sectional designs. Now, they later on said that it was found that people who, and some deaths were also reported, and it was found that people who are having certain risk factors or an exposure, like people who went to that live market or had an exposure, were the ones who developed this disease. So they had a virus exposure, even if they could not establish human-to-human transmission. That means they were looking at, ideally, this should have been a case control design, but it has not been a case control design. And it's sort of like a unilateral design that they have had, in which they have looked at people who are admitted to their hospital. Did you go to that market? Did you exposure? So a bit of recall. So goes a bit towards case control design, but not exactly a case control. It's like a cross-sectional design where people are being asked to recall. Then they referred to the spread of the disease to different places according to different time. And also, as you go, I pause the video, but as you go deeper, you'll also find that they have described who are the high-risk groups. So time, place, person descriptions come in, right? So once those descriptions are there, they indicate that it's a descriptive design. Later on, or yes, you can also say these are ecological design. When they mentioned around New Year, so many people would travel and so many buses, so many flights would be there. As many people exchanges happen, the disease could spread. So at a population level, they are trying to say, and also indicating that cases were observed in Italy, in USA, or in Japan, they showed a red color border. Very nice evolution of study designs. Later on, they referred to one ship called the Diamond Princess. Has anyone known about the story of the Diamond Princess cruise? Anyone? Just say yes or no. You haven't? Okay. Let us continue with the story then. I'll just move a couple of slides ahead, and then maybe it's a better position to talk about this particular ship. Yes, here we are. Now, in January, so Diamond Princess is a very celebrated cruise. It goes from China to Japan. In January, people boarded this cruise. Usually, people who are in this cruise are rich and of a particular age band, because rich people usually are in their 50s, 60s, where they're into vacations. Younger people may not manage to get into this kind of a luxury cruise, but whatever. It had a particular profile of people who got into this cruise, and the cruise went to Japan, but was quarantined on the waters of Japan. They were not allowed to get into Japan. A lot of hula baloo, lot of controversy, lot of political debate happened whether it is ethical to quarantine people. But as they quarantined this ship for a couple of weeks on the borders of Japan without allowing people to disembark, people started developing symptoms of COVID. So one case, then multiple cases, and multiple cases. This provided a very good captive population and was perhaps the highest, the population, the highest number of COVID-19 cases outside China at that point of time. This particular cohort helped us in understanding what was the incubation period, what was the infectivity rate, how symptoms manifested, who actually had more severe symptoms, all that detailing could happen. How diseases transmitted, should we do that kind of a zoning? You remember the red zone, green zone, yellow zone? Should healthcare workers be also quarantined whenever they have an exposure? All those questions got answered in this particular study. In this particular, it's not a study, it's a natural experiment that happened, but looks like a cohort. And then we, of course, remember the solidarity trials, which looked at interventions or treatments for COVID-19, right? So this is nature at its best. December 2019, getting into 2020, and that's how study designs also evolved, from a case report to a case series, to cross-sections design, to case control design, to cohorts, and then RCTs, right? If we start reflecting on how vaccination policies were rolled out, then it could be a good commentary on implementation science as well. Right, let's go back and look at the designs that we have spoken. I'll be a bit fast. Maybe we can cover up in under 15 minutes since the previous speaker has already talked about these. I'll be touching on more practical aspects. Right, so when we talk about descriptive designs, we saw that it's mostly describing a story. So who, what, when, where, why may or may not be answered, but yes, exploratory designs, especially those using qualitative methods, could answer why. We want to see trends and we want to understand patterns. Maybe if you repeat these designs over time, these studies over time, you may also be able to comment how time has led to changes, trends, as I said just now. Now, irrespective of whether it is a descriptive design or an analytical observational design, there are strengths and limitations. The strengths, these designs help us in describing things in great details. These are also relatively cheaper as compared to the more robust designs. For example, an observational design could be much cheaper than an RCT. We have an opportunity of covering a large number of people, a huge population as a denominator, and we can generate hypotheses. So we can see which variables are of interest and how we could look at their relationships. But there are limitations. Most of these descriptive designs, especially. So if you look at your case study, case series, ecological designs, or cross-sectional designs, they or even case control designs, they can't really comment on cause-effect relationships. Cohorts can, because they have a prospective element. They are subject to bias. Of course, every study is subject to bias, depends on what methods and resources we have put in. And they have limited scope, of course, depending on the nature of evidence they generate. Let's consider the first study design. As I said, if you look at this pyramid, which is again an oversimplified, rude comment on the quality of evidence, I would again like to reiterate that each study design in itself is a very powerful design. It's like your quiver of arrows, where you have arrows of different styles. You need to know which design needs to be used for which kind of a research question or objective. You should not try to fit in an RCT when you need an observational design. Neither should you try to wait for a number of cases to accumulate when a single case report could be very disruptive. So know all the designs, know it to perfection, and then choose which design you want to use in which situation and for which objective. Case reports. We have seen clinical case reports mostly in the papers. One particular clinical case, and that has been described in good detail, and maybe a discussion also follows at times. These days, many journals do not accept case studies or case reports. So what people do is they combine as a review of literature and a case study. So whenever there is a case study, a background review of literature is also being done so that the paper has some value, and we try to fit the current case study into the context of whatever is already known and what kind of value addition or knowledge addition this particular case study does. But in public health, it could also mean that we are describing particular periods or policies or even institutions or populations. So, for example, the current Ukraine-Russia or the Israel-Gaza conflict that is happening, that could be seen as a very good phenomenon or a very good case study. How people respond or how global politics is affected, or what changes in economical decisions happen. Those can be explained with this as the context. It could also indicate systems reflections. So how systems respond to certain situations, and that can also be developed as a case study. Most journals would publish a case study if one or more of the following are satisfied. If it is a very unusual observation that you have made, or a very established therapy suddenly gets to see an adverse response, so then it becomes a protective one. You can't really wait for if a particular drug causes AMI in people, then you can't really wait for too many AMIs to be reported and you do a prevalence study or a market surveillance. You should immediately report, and that can be a game changer when it comes to treatment decisions. Similarly, unusual combination of conditions leading to confusion. So this again could be an interesting case study where there is ambiguity and we need further insights to be able to put a diagnostic label or reach a decision. It could be a new theory that has come up. So, for example, the famous case study, you can say, the apple falling and then Newton discovering gravity. That can be a new theory as a single case study. He can't just be like waiting to see multiple apples falling, or maybe you would have done that experiment, who knows. It could also be a question regarding a current theory. So if there is a particular hypothesis or current theory that is being practiced, and suddenly you challenge that paradigm, or it could be a personal impact as well. So individuals can also write about themselves or their patients as a particular case study. Many such case studies have been written about people caring for people with dementia, or caregivers of people undergoing renal transplant, liver transplant. So those kind of stories have also been written. I put two examples, and these are usually the titles. They make the title a bit jazzy. It's not exactly a bland scientific title that we get on other designs. Here you see an unusual case, troublesome teeth, search for stones. So some taglines and some jazzed up titles. When we look at case series help in studying symptoms and signs, as we saw in the case of the COVID-19 study, COVID-19 story, or it can help us in giving case definitions where we can define, okay, this is how this particular case could be defined. It can also be used for clinical education or even for reviewing databases or even for research. Now, when we look at case series, it could also come up as a registry. So population-based registries or clinical registries, they can also be seen as case series. And these are fantastic resources for people who have digitized hospital health records, and they can start talking about these cases. This is again one interesting way of looking at evidence, where it's sort of a review, but it's a review of case studies. So in this paper, you see this research team has not collated cases at their particular health center or health facility, but they have looked at different papers, and then from those papers, they have put a table where each case study has been described. Now let's look at ecological designs. These are called correlational designs. Fantastic designs, very rarely taught to us in our medical schools. Ecological designs, they reflect on the population as a whole. For example, suppose I was to say that if the per capita income of Indians could go up by 1,000 rupees a month, what percentage of us would be obese? Or what percentage of us would develop hypertension? Because these are again seen as affluence diseases of the affluent population. These kind of studies, or what if we increase the cost of cigarettes by 10%? What could be the impact on the prevalence of hypertension? If you have to compare these kind of broad level variables, or establish some relationship at the broader level, then ecological designs are fantastic. But ecological designs have a problem as well. Ecological designs many times struggle from ecological fallacies. Since the inference is at a population level, let us consider the second example. If you increase the cost of cigarettes by 10%, what would be the reduction in the hypertension, or what would happen to the prevalence of hypertension? Here, the basic assumption is that people who are smoking, they would be affected. But what about people who are not smoking? They also have secular trends in hypertension. They are also considered somewhere within this entire comparison. So these are not very specific estimates, but very useful for policy making and looking at impact of policies and programs at a scale, at population level. Moving up further in this conversation, we have cross-sectional designs. Cross-sectional designs are absolutely cross-sectional. What is there on the date and time of data collection? We are not here to ask about what happened in the future. Neither are we interested in what is happening, what in the past. Neither are we interested to look at what is going to happen in the future. What is it as of today? That's what we document. That's it. Many times you will find that even if there are surveys, and common designs are, common studies that we have is, let us say, the national census. That's a cross-sectional design. Or many times we say National Family Household Survey, NFHS, health survey. So those surveys, even if the names are surveys, they have some flavors of being analytical. You will find that the NFHS tables are just number percentages. They do not provide p-values or cross-compare across variables. If they do, they could be analytical designs. But what they do at times is they include variables like, have you ever used a contraceptive? Have you ever smoked? So when you start asking them questions and asking people to recall, reflect, then there is an element of temporality and time trends show up. Those are a bit of deviation from the usual absolutely strict surveys, but that's the ambiguity and that's the beauty of research designs. And that's why you find cross-sectional designs moving from pure descriptive designs to analytical observational designs. Same for ecological designs as well. Cross-sectional designs, they measure prevalence. And of course, it's very difficult. It's impossible to comment on what was a cause and what was an effect. But there are advantages. Cross-sectional designs are considered as cheap and quick studies. Cheap means in terms of resources. The data is easily available from records, and it's good for generating new hypotheses which can be tested in analytical designs. The disadvantage is, again, we can't really comment on cause and effect. And we already talked about these survey designs, these common popular demographic health surveys. Now let's look at the case control design. In case control, we are gradually moving towards analytical designs. In the analytical observational designs, we have the case control where we take cases. So the outcomes have already happened, and that's the case group. We choose a control group where the outcome has not happened, but they are otherwise matched, comparable to the cases, but the disease is not in this particular group. And then we ask them certain questions, or we see what variables they have, and then we try to see what kind of associations these variables have, and we compute an odds ratio. The trick in case control study design is in selecting the cases and in selecting the controls. It's only that they should not have the disease. All other characteristics must match. And when we try to select the number of cases to number of controls, it's usually 1:1, but we can go till 1:3, 1:4, many times people say. That means suppose we have 100 cases, we can go up to 400 controls, but don't go beyond that because it makes no sense after that. It loses its efficiency and it becomes an overall resource intensive design then. 1:1 is a fantastic design. If you reduce the number of controls, that means you have 100 cases and just 50 controls, then your study starts losing a bit of power. And what we get an odds ratio. And as my preceding speaker had already spoken, odds ratio, relative risks, these are on a continuum. If you get 1, that means there is nothing to be worried about. If it is less than 1 or more than 1, then we can comment whether it is a protective or a predisposing factor. Case control designs suitable for rare studies, low cost, very rapid, and usually with small sample size. But the disadvantage is that we end up getting odds ratio. We get associations, but we can't really. Already spoken about the Diamond Princess story. Coming to cohort designs, we have a cohort in which some people are exposed and some people are not, and then we see what happens. So there is a prospective element. But many times we can also go back and recruit a cohort in the history and then see, for example, what happened to people who were exposed to the Bhopal gas tragedy. And then we go back and see who all were there around and now what has happened. So that's a prospective design in retrospect. In cohort studies, we get risk calculations. So relative absolute risks or incidence and relative risks. And again, we get a chance to look at risk factors. It's good for rare exposures, but very intensive. We require follow-up into the future. This can be skipped. This is my fantastic team that keeps me on my toes each day. I get to learn a lot as we do different studies and evaluations across different contexts. But it's been more than a decade that we are into different types of study designs and still learning. I would say that even if we read about surgeries in our textbook, the way we do a surgery in practical life could be an amalgamation of different methods. So similarly, even if we know about research methods, there's nothing called that, it's not a rule book that you need to stick and be very true to that design. You can always be creative in mixing and matching different methods as long as it makes scientific validity. Thank you so much. Let's take a couple of questions if we have time.
Thank you, sir. Am I audible, sir?
Yes.
Thank you so much, sir. May I now request Dr. Deepak Pashwani to present a memento on behalf of the institute, and I also request Dr. Abhishek to receive it on behalf of Dr. AIIMS.
Ma'am, there were a couple of questions in the chat window. Can I just quickly respond to them before we close down?
Sir, first we present a memento, then we will take the question.
Okay, thank you. Thank you so much. Thank you. Thank you. Thank you.
Sir, hi, sir.
Hello.
We can take questions because we are actually running out of time now.
Okay, sure. So-
You can choose from the chat box any question that you want to take.
Yes, I'll respond in the chat box. Let's proceed to the next speaker. Thank you.
Yeah. Thank you, sir. Okay, sir.
I would like to invite our next speaker, Dr. Ankit Jain. Dr. Ankit holds MD in Community Medicine and Postgraduate Diploma Health Management and Administration. Currently, he is working as Medical Scientist E, ICMR NIOH, Ministry of Health and Family Welfare. Dr. Ankit has received various awards and is principal investigator of many projects. Over to you, sir, Dr. Ankit Jain.
Word of it.
Is my screen visible? Hello? Hello?
Yes, visible.
Yeah, so good afternoon, everybody. I'm Dr. Ankit Seth from ICMR NIOH, and I would like to first thank the organizer for conducting this national level CME, and I've been asked to present experimental and quasi-experimental design, which you might have learned from the previous speakers that it stands at the top of the hierarchy of evidence as it. So let us just begin with the setup, the backdrop of the RCTs, how it is different from the observational. In observational studies, the researchers does not assign any choices. Whatever happens, just we observe, and there is no manipulation of the independent variables over here. For example, if I can give the example of smoking and lung cancer study, we just observe the smokers. We do not induce somebody or ask somebody to smoke and then see the observations. We just happen to see these smokers and then follow them up and see whether there is certain outcome or not. However, in the experimental design, the independent variables are manipulated. That is that we are not following the natural history of the disease or cases. We are inducing or giving or administering drug or a particular vaccine or a counseling or a particular type of diet. So these are basically different from the observation studies. Now, why this experimental studies stand at the top of hierarchy of evidence? The classical example is one of the, there are many such articles, but one of the articles that was published in New England Journal of Medicine, whether estrogen plus progesterone is harmful or useful in the preventing the coronary heart disease. See the conclusion of the article clearly states that estrogen plus progesterone does not offer any cardiac protection. In fact, treatment should not be prescribed for prevention of cardiovascular disease. So such type of conclusions can only be derived from the experimental studies. Observational studies are limited in a way that such type of conclusions by the virtue of their designs. So let us start with the types of experimental study design. The classical study designs, the classical experimental study designs, which are also the true experimental in its own sorts, are the randomized control trial. Remember the word randomization because we will use the terminology time and again for the description of this type of study design and which is the essence and heart of this type of study designs. The other type of study design which kind of resembles the experimental study design but are not actually the true study designs because there is no randomization involved are also known as quasi-experimental study designs. They are even better than observational, but they do not have the internal validity as good as the true experimental research. So let us start with the first one, which is the RCT, the randomized control trials. It's a very simple, you might have learned about the study prospective. Similar to the design is similar to the prospective element of the course. You can see that the groups are assigned based on the type of treatment or interventions we are giving. So one of the group in which we are giving the intervention or the treatment becomes the intervention group, and the other group which is receiving the placebo, which is receiving the continuing with the standard of care becomes the control group. We follow both these groups and finally we see the outcome, analyze the outcome. This is the true essence of the randomized control trial. Remember that the allocation of the participants, whether it belongs to the control group or the intervention group, is truly randomized in this, and hence it is known as randomized control trial. So let us talk briefly about the randomizations. What is randomization and what are the different mechanisms of randomization and how do we do randomization in RCT? So randomization is purely just assignment the participants to one of the either groups in this RCT based on entirely by chance, and we do not, the assigner or the outcome assessor or the administrator does not have any role in actually deciding whom we should give the treatment or whom we should give the placebo. So this essence is entirely giving the equal chance of both entire participant pool, whether he should belong to the treatment group or whether he should belong to the control group, is known as the randomization. So basically there are few steps in randomization. The first one is sequence generation. So let us, I will give just an hypothetical examination of, say, there are 100 participants whom we want to give both the treatment and control. So there are 50 participants should belong to the treatment group and 50 participants should belong to the control group. Now, how do we decide the sequencing? If we, whether we should take the odd numbers like 1, 3, 5, 7 for the treatment and 2, 4, 6, 8 to the control group, or there should be any other sequence mechanism. So the sequencing of the participant, each participant comes to us and then we decide whether we give treatment group or control group. The sequencing, generation of sequence is known as the random sequence generation, which is essentially the first step. The location concealment. This is again very, very important because as an administrator of the drug, if I am aware that the participant number 4 will be belonging to the control group, but somehow I feel the participant has a very severe disease and I don't want him to get the placebo, but I want him to get the actual treatment, then I would not take him as a number 4. I would keep him aside and take the next participant and give him the placebo and take this participant as number 5, and then I would give him the treatment. So this allocation concealment is very important. We'll discuss this again in the later slides. And finally, the execution or the implementation of the strategy that we had written up in the protocol of the RCT. So sequence generation. How can we do the sequence generation? There are different types of sequence generation. The simplest is known as the simple sequence generation, as the name suggests. We just go to the computer and just go to some software which generates random numbers for us. And this is the most basic type of sequence generation. The other one is block type of sequence generation, in which we take the pool of participants, say for example 10 participants, and we create 2 blocks, like 5 participants would get the treatment and the 5 participants would get the control. Again, the pool of next 10 participants will give 5 and 5, 5 and 5. So this is kind of blocked sequence generation. The third type of sequence generation is stratified, in which we essentially stratified the entire pool of participants into either based on the age groups or sex, like male and female. And then in this stratified group, again, we try to create the treatment and the control group through the random sequence generation. The last one is minimization, which essentially the essence of minimization is that certain basic characteristics should be equally distributed. So if we are having a characteristic X in the treatment group and we are having 15 or 20 such participants in treatment group, we should make sure that the characteristic X is also there in the control group, like 15 to 20, whatever is the number, and we try to balance the background characteristics in both these groups. The second thing that I talked about was allocation concealment. Again, it is the truly the heart of the RCTs, because if concealment is not properly maintained, then there are lots of biases, performance bias and the outcome bias. So there are essentially 2 ways of ensuring which is very rarely followed actually. So what do we do? That as the administrator of the drug, I call some central agency. I place a call that okay, and the patient has arrived, and should I give the treatment or the placebo? And the central agency just replies me on call that this is they have their own sequencing, and then they say that this is the patient XYZ patient, and you give them the treatment or the assignment or the group, the treatment part or the control part. So as an administrator of the drug, I do not have any control whether the participant that I'm facing should receive the treatment or the control. Second one is sequentially numbered, opaque, and sealed envelopes. So again, the hypothetical scene that I mentioned a few minutes back, in which I don't want the patient number 4 to get control, but I want patient number 4 to get the treatment. So I keep him aside and let him come after few of the patients, does not hold true if we are following the sequentially numbered opaque seal envelopes. Now, what happens that I'm presented with the envelopes which are received well in advance, and they are opened only after I write the name of the participant on it. So after writing the name, I cannot go back. Whether it is treatment or control in that particular envelope, I have to follow, because I already assigned it to one of the participant and written the name of the participant. So these 2 are the main principal methods by which we can take care of this allocation concealment. There are few other biases which cannot be taken care of by the randomization. So essentially, randomization ensures that the background characteristics, the confounders are equally distributed, as well as the selection bias of which patient received which treatment or control are controlled by this randomization process. But there are certain other types of biases which are beyond this, and for that we have to follow certain type of masking, or what we call commonly as blinding. So the goal of blinding is to completely eliminate whatever type of biases that we encounter, the potential types of biases. So there are three types of blinding. The first one is single blinding, in which only the participants are not aware of which treatment they are receiving, whether they are getting the real tablet or this is just the placebo tablet. Then the second type of blinding is double blind, in which neither the participants or the investigator who is actually assessing the patient are aware of the treatment assigned on the day of the study. And finally, the triple blind. Ideally, we mostly follow the double blind, but there are certain cases where triple blinding is followed. And triple blinding is a term when the administrator of the drug, the investigator, the participant, as well as the persons who are going to analyze the data or who are going to see the outcome of the patients. For example, if we are giving aspirin for CHD and if we are investigating CHD by 2D echo, even the person who is doing the 2D echo does not know whether the patient has taken aspirin or not. So triple blind, everybody is blind. Nobody knows what is going on. So let us just revise the steps in conducting the RCTs. First of all, we have to prepare a study protocol in which we have to mention the research questions and the objectives, the inclusion and exclusion criteria, the entire study design and the methodology, the sample size, the power, and the groups that has to be included. In the next step, we have to define the study population. What is our study population? Whether these are and what is our target population actually? So whether these are some of the cases of an infectious disease or cancer, or whether we are going to take the study population from the hospital or from the community. So we have to define the study population, and then after defining the study population, after calculating the sample size, the next stage is we select the participant. We recruit the participants. The recruitment of participants, again, based on certain inclusion and exclusion criteria, we have to screen them for the eligibility, and we have to obtain their written consent, and finally, we have to enroll them in these RCTs. The next step is randomization of participants. So we have already gone through the randomization of participants. We have to create the random allocation sequence. I'm just summarizing what I have already said before. We have to generate the sequence. We have to assign participants to either intervention or control groups. And finally, we have to do the allocation concealment. After the randomization, we start the intervention. So we give the treatment or the vaccine or the diet or whatever intervention we have to the treatment group, and the other group either receives the placebo or the group receives the standard of care, the prevalent standard of care that is already been in place. And then the most important thing is we have to monitor the adherence to the treatment as well as the placebo group, and we have to also see the compliance, because in RCTs, mostly there will be a higher loss to follow-up or higher attrition as compared to other studies, because sometimes the participants may not feel comfortable with the drugs they are receiving. They may encounter certain sets of side effects, and they just opt to drop out from the study. So we have to monitor the adherence and compliance of these participants to the intervention. And finally, we have to see the follow-up and analysis. Now, there are two mechanisms to follow up and analyze the outcome in both these groups. One of them is known as intent to treat, in which we analyze all the participants according to the allocation group, even if they are dropping out of the study. And the second one is the per protocol group, in which we analyze the participants as though all of them have actually completed the study, even if some of them have actually dropped out from the study. So I'll try to explain both of them, because both of them have their own pros and cons, and analysis. The outcome analysis is the principal part where we report whether the treatment is effective or not. Randomizing the group into intervention and control. As you can see, the intervention group, some of them, the green box, are receiving the treatment, and the pink box, who are labeled as did not get the treatment are actually those who have not completed the study and they have dropped out somewhere in between. Similarly, in control group, there are green box which are receiving the treatment till the end of the study, and again pink box which dropped out of the study in between. If you see the first row labeled in pink, which is intention to treat, we can see that in intervention group, we are taking yes means that group is included in the analysis. We are including in the analysis both the group that have completed the treatment till the end of study, as well as those who actually dropped out. And in control group, we are not including in the analysis even those who have dropped out. But if we look at the second row, the blue row, which is labeled as per protocol, we can see that we are only included in the final analysis those who have got the treatment till the end of the study, and we are actually dropping those who are not receiving the treatment. Now, let us see one of the actual scenario, classical hypothetical scenario, in which we try to judge which is better. Should we do the per protocol analysis or should we go about with the intention to treat analysis? Now, consider a scenario in which there is a new antibody, and we want to see the effect of this new antibody on cardiovascular mortality with 500 patients. And we hypothesize that this new antibody is similar to placebo and it does not offer any decrease in the CVS mortality. So when we try to randomize, see the antibodies 500 patients and the placebo 500 patients, we see that in the antibody group, 100 are non-adherent. That means that they are not taking antibodies, or they are just not compliant, or they just dropped out the study. And in placebo group, only 25 of them are non-adherent. However, we see that in both the groups, actually 100 patients have died. If we see the antibody group, a total of 100 patients have died. And if we see the placebo group, total of 18 plus 12, again 100 patients have died. Now let us see the analysis. Let us see first try to do the per protocol analysis. In per protocol, we only take the patients. The numerator is only those, the denominator is only those who have actually completed the treatment. So in the antibody group, if we are doing per protocol analysis, we can see that 50 out of 400, because 50 of died and 400 were adherent, it comes out to about 12.5% mortality. And in placebo group, if we are doing the per protocol analysis, again, we can see that 88 out of 475 have died. So 88 divided by 475 is 18.5% mortality. So at a first glance, if we are just doing per protocol analysis, it seems that the intervention has actually reduced the mortality. But because the number of non-adherent patients in both these groups, as well as the patients who are dying in this non-adherent group are different, if we are doing intention to treat analysis. So in ITT, if we see a total of 100 patients have died in the 500 group, so 20% mortality. Again, 100 patients in placebo out of 500 patients have died, so again 20% mortality. So intention to treat actually preserves the prognostic balance between both these groups. And if we are seeing the intention to treat analysis, we see that both of them have actually 20% mortality, and the antibody does not offer any protections against cardiovascular mortality. So intention to treat again is an important example of what type of analysis should we follow per protocol or ITT. The next important thing is, since RCT stands at the top of evidence, it is quite imperative that any RCT, any and all RCT should be should adhere to certain strict guidelines and should have a quality control over them. So we will talk about how this adherence to guidelines should be made. Quality should be monitored, and any adverse events during the course of the entire study should be reported, and there should be standard mechanisms to report these AEFIs. So we'll talk about that later. Let us come to the bias. Previous speaker mentioned that any study, be it observational or a case study or case report or the systematic review and meta-analysis, so entire hierarchy of evidence, pick up any study, it will be bias will be there in these studies. So again, there are potential source of bias in RCTs too, the major being the selection bias. But however, in true RCTs, where we are doing the randomization through proper random sequence generation as well as allocation concealment, This takes care of the selection bias to the maximum extent. The second type of bias, which I briefly touched upon in previous slide, was the performance bias, in which the caregiver or the administrator of the drug have some sympathy or empathy to particular patient, and he tries to include that particular patient in the treatment group. So again, blinding, single blind, double blind, triple blind are the types of blinding that taken care of or minimize such type of biases. The third, again, the third type of bias, which is often neglected, but which is very important, is the detection bias, the outcome assessment. So the persons who are actually analyzing the outcomes of the patients are a potential source of bias reporting. So the triple blinding, in which the analyzers are also blinded to the group of the patients, essentially minimizes this detection bias. And the last one is the attrition bias, the loss to follow bias, none other than the non-compliant groups. So intention to treat analysis, which I just described before, takes care of this bias and minimizes this attrition bias, the reporting of this attrition bias in this outcome as far as possible. So let us see different types of RCT design. The classical RCT design we have already described in the past. There are two groups, treatment and the control. So this classical RCT design is also known as parallel designs or the two-arm design. Because why it is known as parallel? Because once we are assigning a group of participants to either treatment or the placebo or control, it remains same throughout the study. It will remain in that group throughout the study. So you can see from the diagram that if somebody is allocated to treatment group, and in future he will remain in the treatment group, and the outcome is he will be suffering from disease or he will report no disease. Similarly, in the placebo group, those whoever are placed in the placebo group will remain in the placebo group till the end of the study. A very simple example is a clinical trial testing the different doses of pain relief drug. One group receives the drug, the other group receives the placebo, and all groups are followed simultaneously. And the effectiveness of these doses is compared based on the pain reduction in each group. So this is a classical example of parallel RCTs, and most RCTs are parallel RCTs. The second type of RCT, which is quite important in certain scenarios, is crossover design. Now, what happens in the crossover design, that the participants here acts as their own controls. How? Let us see examine the figure that I have presented here. See the placebo group or the treatment group. So the participants who are receiving the treatment group, after some period of time, say for example, quarter or 6 months or a year, they are weaned off from this treatment. Essentially, there is a brief washout period where we allow the effect of the drug to wean out from the body, and then we place the same set of patients to the placebo group. So we stop giving them the treatment, and they are now essentially the placebo. And same thing happens in the placebo group. So those who were previously not receiving any treatment, after the brief period of washout, will start receiving the treatment. And then we measure the outcome. So there are actually we measure the outcome at two different time frames. One while they were in the treatment group and the placebo group, and again after the switchover happens, the treatment and placebo groups are again measured for their outcomes. So this type of design is known as crossover design, and it is essentially in certain scenarios in which we want the effect of drug due to certain ethical issues or for other reasons. We want entire pool of participants or the patients to receive the drug. So in this case, the entire set of patients are receiving the drug. Some of them are receiving in the first set of time frame, and some of them are receiving the second frame of time frame. So a very simple example I have presented, a trial comparing the effect of two different diets on cholesterol levels. So participants are randomly assigned to follow diet A for a month, then switch to diet B after a washout period. And we measure the cholesterol level and compare the effect of diet on the cholesterol in both these groups. The third type of RCT design is cluster randomized design. Here, essentially, the unit of randomization is not the patient himself or herself, but rather than it's a group of individuals. So we take entire village, or we take entire school, or we take entire workplace as a intervention workplace or site, and the other group is the control. For example, consider a fictional anti-malaria vaccine trial. So population is the cluster of participants living in different villages that meet the study inclusion criteria. Then we randomize these clusters. We randomize these villages, say for example 40 or 50 villages, and we randomly put some villages in the intervention group which receives the vaccine, and we put some villages in the control group which does not receive, which receive the standard care. And then we follow them up and we see the outcome, and then the outcome is analyzed based on this cluster of data. So this is the cluster randomized design. Again, a very simple example, we have to test the effectiveness of a hand hygiene program in reducing infections in hospital. So we randomly assign different hospitals to implement a new hand hygiene program, and then we measure the infection rate across these hospitals. So this is all about the different types of RCTs. Obviously, I don't need to emphasize much on the advantages and disadvantages of RCTs. The advantages being it is the best evidence generation mechanisms any study could provide. It eliminates selection bias. It eliminates the different types of loss to follow bias. It allows for generalized comparability. It has very high external validity. It has very high internal validity. At the same time, it has got its own disadvantages, time and money being the most of them. So it's time consuming, it requires a lot of resources. There are certain ethical issues in interventions because we are choosing a new drug or a vaccine or trial. So it is encountered with a lot of ethical issues too. And sometimes it is difficult to conduct because of the non-adherence of the patients to certain sets of treatment protocols.
We are running short of time, sir.
Yes, sir. Just give me last 5 minutes, sir.
2 minutes.
Okay, sir. Thank you, sir.
Please.
Thank you. So RCT is, as I told, because it is a very high evidence generation mechanisms, we have to follow certain set of guidelines. And fortunately, we have consolidated standards of reporting trials known as consort statement. And any researcher who wants to conduct an RCT should adhere to this consort statement. This is the diagram of the consort statement. The researchers should ideally present this, the flow chart in the manuscript or the final publication. How he has actually, how many participants were included in the intervention control, how the losses to follow up. This is the standard consort 2010 statement checklist. You can Google and download the entire checklist. I'm not going to talk much about the checklist over here. And finally, any RCTs that has to be conducted in India has to be a priori registered with the Clinical Trials Registry, CTRI. And the registration has to be prospective. Like we cannot register once we have started the trials. It has to be registered a priori, and then we have to start the protocol. It is hosted by AIIMS, National Institute of Medical Sciences. So, okay, just 2 slides about the quasi-experimental designs, because in the beginning I talked about true experimental vis-a-vis quasi-experimental. So quasi are, the term is like resembling. So they are not true experimental because the randomization does not happen over here. So if not randomization, what happens? There are only 4, I would take just 1 minute to explain these 4 type of studies. One is non-randomized control group design, which is essentially similar to RCTs, but the patients are not allocated in a random fashion. They are allocated in purposive fashion. The second one is pre-test, post-test single group design. So essentially, there is one group. We give a certain set of intervention in that group, and again we measure the outcomes in the same set of groups. So essentially, it's a pre-test, post-test. The third one is a non-equivalent control group in which the groups are similar in all fashions, and we choose half of the participants to get a treatment and half of the participants to get control. And finally, time series design, which is similar to pre-test, post-test, but there are different time frames in which we are assessing the outcomes. So this is all about the COSI designs. The advantage is it has higher external validity than true experiments, but higher internal validity than other non-experiment. But the disadvantage is that it has a very low internal validity than true experiment because we are not following the randomization. So this is all from my side. Thank you. Thank you organizers for giving me time, and thank you AIIMS for conducting this workshop. Thank you again.
Thank you so much, sir. May I now request Professor Agarwal to present a memento On behalf of the institute, I also request Dr. Arun Kumar sir to receive a memento on behalf of Dr. Abhi.
Thank you, Dr. Inkes.
A ver si se muera más fácil. Pongo y tú también.
Thank you very much. Thank you
Moment
very
of
much for your
close.
time.
Thank you, sir.
Bhumika, tell the audience to join tomorrow sharply at 1:55.
For tomorrow's session, I will session starting 2:50 to 55.
Maybe not to 1:55.
Sorry, 1:50.
Closing the session. Please.
We are closing today's session. Please join sharply at 1:50 for tomorrow's session. Thank you all.
Apa marah marah legend itu. Baik sukses dalam.
Super sir को बोलना था। क्या क्या?